السلام عليكم ورحمة الله وبركاته. بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على رسول الله صلى الله عليه وسلم. Welcome in our second day in the SGH Rheumatology Symposium for 2022. It's our pleasure to have you in our second day. We'll start today with an interesting topic with our Professor Dr. Jamal Atiyah, Consultant and Head of Rheumatology Department, Saudi German Hospital Asir. He is also the Professor of Rheumatology in Faculty of Medicine at Azhar University, with an interesting topic about fibromyalgia overview. Welcome, Dr. Jamal.
السلام عليكم.
عليكم السلام ورحمة الله وبركاته.
دكتور خالد السكرين كده واضحة؟
لا لسه not yet. Share screen from the bottom. Yes. تمام.
إيه دكتور خالد؟
Clear.
Yes, okay. السلام عليكم. Today is second day of Saudi German Hospital Riyadh rheumatology event. Today, inshallah, I will give highlight about the fibromyalgia. Fibromyalgia, it's very common, especially with chronic pain disease, especially in field of rheumatology. Just to highlight about these problems and how can diagnosis and the treatment available in marketing. As we know, the patient with fibromyalgia have a lot of problems: muscle tension, limited activity, fatigue, depression, muscle strength. But still, until now, the main chronic problem of patient with fibromyalgia. The pain in fibromyalgia is a chronic type. The chronic type of pain is we received by unmyelinated C fiber in speed up to 1.2 meter per second. The autoimmune and inflammatory disorder, one of causes of the chronic back pain, but it represents about 2 to 3% in total population. Also, mechanical disorder or degeneration disorder like osteoarthritis also represent one of causes of the chronic back pain. But idiopathic pain syndrome, fibromyalgia, one of this one, plus headache, irritable bowel syndrome is the main cause of chronic back pain. Chronic disorder pain, it is represent about 20% from total population, also can be coexist with inflammatory and mechanical disorders. Actually, we have many types of pain, nociceptive pain, like burning pain. This is due to noxious stimuli. Also, we have neuropathic pain, like herpes zoster, post-viral infection, diabetic neuropathy. This is what's called neural damage. And we have inflammatory pain due to an inflammatory or secreting inflammatory cytokine. And this type of pain is due to inflammation. And the main common type, central pain, amplification or acceleration. And this type of pain of fibromyalgia due to abnormal pain process by central nervous system. After the impulse is taken from the skin, the impulse of pain is taken and reached to the dorsal horn of spinal cord. This message after reach to spinal cord, the neurotransmitter or pain neurotransmitter material, especially glutamate and substance B, is secreted from pre-cleft to cleft in spinal cord. This message will be sent through ascending spinothalamic tract to perceived as a pain message. After perceive this pain message, the descending tract carry impulse back to the dorsal horn. This is the normal pathway of the pain message. In this diagram, as we see here, after the touch of the nerve, the pain is go to spinal cord and we perceive the pain as a painful message. But in patient with fibromyalgia, minimal stimuli affect the nerve, lead to secrete neurotransmitter or neuropain transmitter, especially glutamate and substance B. So the patient perceives this one as a highly pain threshold due to in the form of hyperalgesia and allodynia. So the main cause of the pain in patient with fibromyalgia due to secretion of glutamate and substance B as a pain neurotransmitter. Amplified the pain in fibromyalgia due to dysfunction in CNS. And this confirmed by hyperalgesia, amplified from painful stimuli, and allodynia. This result from normal stimuli. Anybody can perceive this one, but the fibromyalgia patient perceives this as a severe pain. And this is supported by increase the level of pain transmitter, glutamate and substance B. The function MRI can be demonstrated or can be confirmed by low intensity stimuli in fibromyalgia compared to high intensity stimuli in control persons. In this diagram, as we see here, stimulus intensity, the normal pain curve will be deviated to the right side. But patient with fibromyalgia, the curve will be deviated to the left side in the form of hyperalgesia as well as allodynia. In this study, 3 separate studies, as we see here, substance B was elevated in fibromyalgia patient compared to healthy control. Also, significant higher level of glutamate in fibromyalgia compared to control healthy persons. So what is fibromyalgia? It is most common rheumatic diffuse pain. Second, up to 5th most prevalent rheumatic disorder. This syndrome is chronic widespread muscle pain characterized by chronicity, non-inflammatory, with fatigue and tender point. Patients with fibromyalgia have insidious onset of diffuse soft tissue pain. Pain increase, especially at the morning, with weather change and anxiety and stress. The patient also have pain improved by mild physical activity and stress reduction. And this type is non-restorative sleep. He cannot full sleeping times. Also, the patient with fibromyalgia have abnormal non-rapid eye movement, generalized fatigue and tiredness, chronic headache and anxiety, irritable bowel syndrome, and morning stiffness all over the body. Also, the patient with fibromyalgia have a depression, reduced physical activity, decreased social interaction, cognitive vague, subjective, non-comfortable. The patient all the time complaining from paresthesia as well as swelling joint. But actually, if we do examination to the joint of the patient, we cannot see any swelling of the joint, but the patient feeling as swelling as the joint. All these symptoms were wax and wane, on and off all the times. So the main complaint, the most complaint of the patient with fibromyalgia, sleep problems, fatigue, cognitive dysfunction, and still the pain, the landmark of the patient with fibromyalgia. Abnormal, the causes of the fibromyalgia, it is abnormal high level of substance B, especially in spinal fluid. Substance B is important in transmission, amplification of pain signs to and from the brain. The area of brain activated with mild tactile pressure is 12 in fibromyalgia compared to 2 in control. So the volume control is turned up too high in brain pain centers. The familial tendencies, genetic have a role for fibromyalgia, triggered by certain disease, especially chronic pain disease like rheumatoid systemic lupus, peripheral pain syndrome, infections, physical trauma, psychological stress and distress, hormonal alteration, even vaccine can be causes of the fibromyalgia. At the initial, the patient have damage or inflammation of the tissue. This one is disorder sensory process, followed by or consequent by distress, decreased activity, isolation, poor sleep, and maladaptive illness. All these symptoms will return back to increase the initial symptom of patient with FM. The most common in all the country, in a state, is 2 to 5% from total population. Only 1 to 5 can be diagnosed. Diagnosis takes time. Average is 5 years. The most patients are between 25 up to 60 years. The female is more common diagnosed than male. In this diagram, as we see here, percentage of FM in all the country in Europe and state, as we see here in the France 1.5, and Italy up to 3.5 from total population. The risk factor for FM relative is common or highly risk can be affected by FM. Environmental factors, especially physical trauma or injury, infection, or other stress. Female, as I said, is common 7 times more than men. Who get fibromyalgia affect as many as 1 in each 30 American. The most common age is middle age, especially female. Male and children also can be disorder affected, more likely in chronic pain disease like rheumatoid systemic lupus. Other family member with fibromyalgia can be affected. Lower income and low education can be affected by fibromyalgia. The prevalence increase up to age of 80. Clinical feature is chronic widespread pain, tenderness, buoyant, and other symptoms like fatigue, chronic headache, subjective, not objective, morning stiffness, subjective numbness, tingling, as well as sleep disturbance. Patients with fibromyalgia have involved other area of chronic pain. If we look for this diagram, as we see here, the patient with fibromyalgia have more tender point, especially in all over the body. In thoracic area, the patient with fibromyalgia up to 72 compared to 24 of control pain, chronic pain controls. In lumbar spine, as we see here, is 79 in patient with FM compared to 46 in control or chronic pain controls, as well as cervical pain in patient with fibromyalgia is highly significant, more than chronic pain control in this study. 20% of patients with chronic pain syndrome have concomitant fibromyalgia. Because the patient with fibromyalgia even diagnosed with other pain-related condition, FMME go undetected. Actually, we as a rheumatologist, we concentrated the main problem of the patient, especially if came by rheumatoid or systemic or osteoarthritis. And sometimes we forget to mention about the fibromyalgia in this patient. To diagnose the patient, we need some steps. First, should be check the chronic widespread pain up to 3 months. Rule out other conditions that will be presented with chronic widespread pain. General physical examination, radiological examination, selected lab, all should be done and all within normal range. Confirmed presence tender point. To confirm it or to diagnose FM, we need 11 hour of 18 point. After this point, we confirm the diagnosis of fibromyalgia. Differential diagnosis, rheumatic illness, chronic pain disorder, infectious disease, hypothyroidism, and to consider concurrent system illness and primary sleep and mood disorders. ACR criteria for diagnosis, as we see here, the widespread pain or tender point should be more than 3 months. The tender point above and below the waist, bilateral in axial skeleton. Manual tender point examination, as I said, 11 out of 18. The fibromyalgic tender point on digital palpation, the palpation force about 4 kilo in the range of 1.5 centimeters. PCR criteria have a sensitivity 88% and the specificity about 80%. As we see here in this diagram, the red tender point, this is the ACR tender point, and the green one is the control one. The patient with FM have a global pain disorder all over the body. ACR classification criteria is focused on 18 points. But in this diagram, as we show here, the pain in fibromyalgia is widespread all over the body. The power of blemish of the finger in this diagram, this is the power of press of our hand to examine the tender point in patient with fibromyalgia. Actually, after the patient diagnosis, the significant improvement in patient satisfaction after he know their problems. So the significant improvement after the patient know their problems. How to treat the patient with fibromyalgia? The patient with fibromyalgia have a chronic condition should be managed by medication as well as physical modality. The medication therapy is largely symptomatic as no definite treatment nor cure for fibromyalgia. Who should be treated this one? Actually, more than 50% with patients with fibromyalgia go to primary care physician. Only 16% is visit rheumatologist. ECR suggests the rheumatologist serve as a tertiary care. Other specialty can be shared as in management of patient with fibromyalgia, mental health professionals, physiatrist, and the pain management expert. Actually, the intervention with patient with fibromyalgia should be multi-models. Patient education, cognitive behavior alternative therapy, pharmacotherapy, physical therapy, psychological support, as well as address comorbidity. Non-pharmacology, strong evidence should be do or advise the patient to do exercise. The exercise, physical and psychological, increase the aerobic performance and improve the pain efficacy, not maintained if exercise is stopped. Cognitive behavior therapy, improving in pain and fatigue. Patient education and self-management. All these steps should be combined to treat the patient with fibromyalgia. Modest evidence for non-pharmacological therapy, strength training, hypotherapy, biofeedback, and planotherapy. Weak evidence like acupuncture, chiropractic, electrotherapy, ultrasound, and no evidence to inject the patient by steroid in tender point. Regarding the pharmacology, strong evidence, amitriptyline, cyclobenzaprine, pregabalin, and digabalin, this is recommended for the patient with fibromyalgia. في modest evidence, dopamine agonist, tramadol, SSRIs, weak evidence, growth hormone, 5-hydroxytryptamine, no evidence to give the patient opioid or steroid, even non-steroidal is not recommended to give the patient with fibromyalgia. The FDA until now is approved 3 medicine, and this 3 medicine is famous on our pharmacy. Cymbalta, this is the recent, Lyrica, Safila, but regarding me, I am still used the best one, amitriptyline, and because this one not have any more side effect this in compared to these 3 medicines. The SNRIs act by inhibition, augment descending inhibition via increase norepinephrine and serotonin through descending pathway of pain transmission. Also, the pregabalin and digabalin facilitate decreasing substance being released in inflammatory state as well as glutamate release through the descending pathway of pain in spinal cord. The patient with fibromyalgia, the prognosis is more or less is not good. The patient treated in primary care setting and those with recent onset of symptom generally have a better prognosis. With resolution of sleep disturbance may be resolved totally. Aggressive physical therapy in critical in those who do not respond. About 5% do not respond to any form of therapeutic intervention. The patient not hardly systemic disease, no progressive structure or organ damage. Most patients in special practice have a chronic persistent symptoms. The primary care patient more commonly report complete remission of symptoms. Most patients continues to work, but up to 50% are still disabled. Most patient quality of life improve with the medical management. Finally, the fibromyalgia is the most common chronic widespread pain. Central sensitization and excessive release of neurotransmitter pain like glutamate and substance B. Diagnosis should be based on American College of Rheumatology criteria. Exclusion of other disease is very important, especially of chronic rheumatic disease. A treatment both pharmacology and non-pharmacological. The patient commonly seen with other chronic pain-related condition. Don't forget to see this fibromyalgia in patients with chronic rheumatic disease. FM diagnosis is the key to successful management. Thank you.
Thank you so much, Professor Dr. Jamal. Mashallah, nice presentation for a very important topic, very commonly seen in the clinical practice.
Yes, very common. Yes. But sometimes missed due to we concentrated on big problem of the patient.
The patient is highly investigated. All investigations are fine in spite of the complaint of the patient. In your clinical practice, do you advise psychiatric clinic visiting for such patients?
Sometimes, if you give if you reach to a good diagnosis and give the patient proper medicine, and the patient not get improvement, it is better to advise to see by psychiatrist.
Multidisciplinary. So our medications are enough sometimes. Yeah, do we need to advise the patients for lifestyle modifications or something?
Yes, yes. As I said before, the multidisciplinary, we treat the patient by many ways, not medication only. Yani not depend mainly on medication. Should be depend in physical and environmental factor, have a big role for the causes of the patient with fibromyalgia. So should be rotate the patient to many clinic until he get the good improvement.
Medications are important but not enough. So in your clinical practice, which medications do you start with?
As I said, the amitriptyline is the best one. Regarding Cymbalta and other medication, as I said in the lecture, actually have too much side effect. Amitriptyline, my experience is don't have any addiction or any maintenance. Also, no side effect, and we can give up to 50 milligram. Actually, most patient can be improved from 10 up to 25, but we can reach to 50 milligram daily at bedtime.
Do you advise any combinations?
If we do combination, we increase the side effect. It can be changed. Yani if not improved, for example, for amitriptyline, we can change to Cymbalta, but not give both together.
Yes. Nice. Thank you so much, Professor Yaman. Nice presentation. Nice to meet you. Thank you so much.
Thank you, Dr. Khaled. Thank you. شكرا لكل الحضور.
We'll shift now to our second presentation with my dear friend, Professor Dr. Ibrahim Al-Hamoud. He is the chairman of the Medical Specialties Department in King Fahd Medical City. He is the chairman of the Saudi Rheumatology Scientific Council and the Saudi Commission for Health Specialties. Also is the vice president of the Saudi Society of Internal Medicine. Welcome, Dr. Ibrahim.
السلام عليكم ورحمة الله وبركاته.
دكتور إبراهيم.
حياكم الله جميعا. It's my pleasure to be with you حقيقة. And before I start, I would like to thank Dr. Khalid for inviting me to be with you today. And nice to see our friends, particularly Prof. Jamal and the others. So حياكم الله جميعا.
شكرا دكتور. شكرا جزيلا.
Prof, if you can stop share screen so I could share my screen. يعطيك العافية.
Okay, go ahead.
Thank you very much. Okay, so I'm going to talk over the next 30 minutes about a very important and complicated little bit topic, thrombosis and SLE. So first of all, why this is important? Because I think the incidence and the prevalence of a thrombosis in lupus patients are high and should be considered whenever we think about SLE or dealing with the lupus patient. Now, if you look to the incidence of a thrombosis, it's around 26.8 and it goes up to 52 per 1,000 patients per year, according to the disease duration and also according to the disease activity. It's very important to all of us as the rheumatologists to keep in our mind that the most frequent cause of death are active disease as well as thrombosis and infection. So if you look, we most of the time when we deal with SLE, we think about the activity, the immunosuppressive therapy, which is a cornerstone of management of SLE. But look again to thrombosis, it's equal incidence and prevalence in the cause of the death of those type of patients. So we should think about the thrombosis whenever we are dealing with lupus patients. And then it's very important to think about the risk factor for thrombosis. The high risk or prevalence of thrombosis in SLE cannot be explained by only the risk factor, the traditional risk factor that we know in the other populations, such as obesity, dyslipidemia, hypertension, diabetes, smoking, and so on. That factors, yes, are important, but cannot explain the high prevalence of thrombosis in lupus. So what's there? What else there? There are several risk factors, including inflammatory risk factors. That's why we have to control the disease. We have to make sure that there is no activity when we are handling a patient with lupus and thrombosis. There are factors related to the lupus itself, like disease activity, disease duration. Some antibodies are related to the increased risk of thrombosis and lupus nephritis. It's considered one of the risk factors for thrombosis. Some medications actually increase the risk of thrombosis, and also there are several factors hopefully going to be explored over the next 30 minutes. So what's important for us as rheumatologists is the active disease. Inflammation, we know, it reduces the fibrinolytic activity through the upregulation of production of prothrombin activating factors. So the anticoagulant effect of protein C pathway is also impaired due to the downregulation of thrombomodulin in such patients. Lupus nephritis, as I say, is considered as an independent risk factor and increased risk of thrombosis regardless of the other features of the disease. Now, as you see in this busy slide, it's not a matter of the slide, just to draw your attention that there are several inflammatory cytokines that lead to increase of thrombosis through several effective pathways. Some of them, like TNF-alpha and interleukin-6, through the dyslipidemic effect, they would increase the risk of the thrombosis, and so on, as you see in this slide. Some medications that we use it as a cornerstone of management of lupus, like corticosteroid, are well-known risk factor for cardiovascular diseases, including thromboembolic events, and so on. So we have to keep it in our mind. It's a multifactorial risk factors. Now, when we look to the pulmonary embolism, okay, in patients with SLE, it's very clearly now the discrepancies between the DVT risk factor, which is very, very significantly higher in SLE patients as compared to the general population. The same when we look at the BE in national-wide cohort study, as you see in dots, which representing the SLE, as compared to the general population, it is a significantly higher in lupus patients as compared to the general population. And that could be explained, as I said, by a multifactorial reason. It could be related to the traditional risk factor, could be related to the inflammatory cytokines, could be related to the SLE itself, or to the medication that's used for treatment of SLE. One very well-known and very well-established concept for thrombosis is the presence of antiphospholipid antibodies. Antiphospholipid antibodies, or APLA positivity, nowadays is considered one of the classification criteria of lupus. The prevalence of specific anti-phospholipid antibodies is variable, but in general, around 1/3 of lupus patients, they will have positive antiphospholipid antibodies. And then whether this carries a risk for thrombosis and those they will develop thrombosis in the future or no, that's a debatable area, but of course, it's a risk factor for thrombosis. And the prevalence of thrombosis in lupus anticoagulant negative or anticardiolipin antibody negative is around 10 to 18%, which means that lupus patients, even in absence of antiphospholipid antibodies, they are at higher risk of thrombosis as compared to general population. But again, presence of lupus antiphospholipid antibodies, as you see in the higher line, it carries increased the risk to be 42% and 40% in anticardiolipin antibody, which almost triple the risk factor in the presence of antiphospholipid antibodies. Several hypotheses and proposed pathogenetic factors for the antiphospholipid antibodies are there, but we know clearly that the antiphospholipid antibodies increase the risk for both arterial and venous thrombosis. And this is very important when we touch or we talk about the treatment, to think about the antiphospholipid antibodies for both arterial and venous, not only venous risk factor. Corticosteroid, which always I'm saying for my juniors, corticosteroids are our friend, but again, corticosteroid is our enemy when we are treating the patient with corticosteroid. It's a cornerstone, there is no doubt, it's a cornerstone for treatment of lupus, but it has numerous metabolic side effects. It has been found that patients on 30 milligram corticosteroid has 60% greater 2-year cardiovascular risk than do patients with lupus with the same disease activity and traditional risk factor, but without steroid. And I would like from this spot to encourage all of you, please work together to stop steroid if possible. We know sometimes if impossible to stop steroid, in such condition, try to minimize the steroid as low as possible to minimize the side effect and the increased risk here about thrombosis, but we know a lot of side effect for steroid. So we need to monitor steroid. We need to use steroid sparing agent in the clinical care of lupus patients. So corticosteroid have been associated with thrombosis. Several, again, mechanisms proposed, probably mediated by endothelial damage and accelerated atherosclerosis. On the other hand, the anti-malarial drugs, mainly hydroxychloroquine, by blocking TLR-like receptor 7 and 9, it inhibits the interferon production and then reduce the risk of atherosclerosis and thrombosis. And again, anti-malarial agent should be started on all lupus patients, regardless the clinical manifestations, unless it's contraindicated. Should be continued throughout the life unless contraindicated or patient cannot tolerate the anti-malarial agents. Is there other risk factor? Yes, there are other risk factors that could play a role, like the plasma homocysteine level is an independent risk factor for atherosclerosis, arterial thrombosis, possible venous thrombosis, and homocystinemia is detected in around 15% of lupus patients. Again, other traditional factors that we all know it, but again, we should keep it in our mind. Sometime in busy clinic, looking to the lupus patient, we think about the lupus activity and we thought about immunosuppressive therapy and so on. But again, we have to keep in our mind, lipid profile should be checked at least twice per year, because we know they are at high risk to develop a dyslipidemia, which considered the risk factor for thrombosis. Statin might play a role here and reduce the mortality and the cardiovascular disease in lupus patients in those who have hyperlipidemia, because in those without hyperlipidemia, there is no clinical trial that shows a benefit effect of statin to reduce the risk of thrombosis. Vitamin D is a very hot topic whenever we talk about autoimmune disease or autoimmune related events. So low vitamin D correlate with VTE, venous thrombosis, as well as arterial thrombosis in antiphospholipid syndrome patients. And vitamin D insufficiency occur in up to 70% of ABS patients. In Saudi population, a population-based studies found that 90% of women, they have vitamin D insufficiency, and 85% of men have vitamin D insufficiency. Vitamin D deficiency ranging in our lupus patients between 11 to 50%. We know vitamin D inhibit TLR4, MID88 signaling, and several inflammatory cytokines, endothelial activation, and activate the inflammation. So vitamin D also associated with complement activation. and placental insufficiency and preeclampsia. And therefore could be, I'm saying could be because it's very difficult, to do a study and to do and to prove the clear causality between vitamin D and thrombosis. But again, it's one of the trigger factors that easy to be corrected in our real life. Now, when we're back to thrombosis initially, 13% of lupus patients develop cardiovascular events, ischemic heart disease, ischemic CVA, ischemic peripheral vascular disease, and death due to thrombotic events. Even ischemic and thrombotic events at unusual site is more common in lupus patients as compared to the general population. So we all know now that thrombosis is not uncommon in lupus patients. It's multifactorial. How can we manage those type of patients? Now, a very hot topic, DOACs or direct oral anticoagulants as compared to the warfarin. And still till this moment, today I have a patient who was started in DOACs from thrombosis clinic in our hospital. Despite this patient developed 2 more thrombotic events, in spite being on DOACs. We recommended them to stop it, and good thing that the patient accepted our idea and she started warfarin and she monitored her INR. Is DOACs indicated in our patients? Let us see. Now, DOACs, there is no doubt, it has advantages. First of all, it's a fixed dose. No routine monitoring. Very fewer drug interaction. It does not interact with the food. We know now warfarin interact with the vegetables. So you have to instruct your patient about vegetables. You have to instruct your patient when they start many antibiotics to stop or increase or decrease the dose. So warfarin is not a simple drug, but is DOACs is a good drug in our patients group? Let us now look to the evidence about this. We all know the RAPS, which is rivaroxaban and antiphospholipid syndrome. They use 20 milligram versus standard intensity in warfarin in 116 patients with first venous thromboembolic events or recurrent while on subtherapeutic or no anticoagulation. Patients with arterial were excluded. And remember, lupus patients at higher risk for both arterial as well as venous. And the primary outcome was the percentage change in the endogenous thrombin potential for rivaroxaban did not reach the non-inferiority threshold. There were no thrombotic events during the 7 months follow-up, and this is why some people, from thrombosis point of view, thrombosis specialized physician, they still use rivaroxaban based on this lab-oriented study, and this was only for venous. There was no arterial thrombosis. But when we look to the TRAPS, when they use the rivaroxaban 20 milligram OD, and they compare it to warfarin with target INR 2.5, 120 patients triple ABL positive thrombotic ABS. This study was terminated prematurely because of higher risk of thrombosis. 4 strokes were developed and 3 MI, arterial thrombosis, to none as compared to patients on warfarin. Now, there is other trial that compared rivaroxaban versus BKA, vitamin K antagonist in ABS. It's non-inferiority trial in 190 patients with thrombotic ABS. 60% they have triple ABL positivity, and they used rivaroxaban versus vitamin K antagonist, which is warfarin, with target INR 2 to 3. The recurrent thrombosis rate was 3.9 on rivaroxaban versus 2.1 in warfarin. And look to the last statement, stroke occurred in more patients receiving rivaroxaban 9 events versus 0 in warfarin patients. The post-hoc analysis suggests that those who were given rivaroxaban has a higher risk of recurrent thrombosis, those who have arterial thrombosis. levodoracemosia or levodoreticularis, which we know presence of this type of skin eruption make the patient at higher risk for arterial thrombosis, and ABS-related cardiac valvular diseases. In this condition, I would say personally, please consider them as contraindicated for DWACs. ASTRO-ABS is another study that tests or examines another DWAC, which is apixaban, for secondary prevention of thrombosis in ABS, which is mimicking our real-life secondary prevention when the patient present already with thrombotic events. They use 2.5 milligram twice daily, and they compare to the INR with intensity that's 2 to 3 in thrombotic ABS patients. Look here, it was modified twice. And why? Because of higher rate of thrombosis in patients with history of arterial thrombosis. They go up to 5 milligram twice daily instead of 2.5 milligram. Despite that, this makes it very difficult for enrollment of the patient in this study, and it was not give an encouraged result for using apixaban in patients with thrombosis already. Looking to the meta-analysis, which help us to build up, the decision. Direct oral anticoagulant or DWACs are not effective and safe in all antiphospholipid syndrome patients. Triple positivity, please avoid these agents in such patients. Most recurrent thrombosis occurs within 12 months after DWACs initiation. So bottom line, those with triple positive antiphospholipid, those with higher number of clinical criteria for ABS classification, those with prior thrombosis while vitamin K antagonists, patients who were treated previously with anti-factor 10 inhibitors, those with history of small or arterial vessel thrombosis, please avoid the DWACs in such patients. Now, this meta-analysis, they compare again DWACs with vitamin K antagonists. And again, when there was comparison, the risk of major bleeding or mortality was increased without achieving statistical significance. So with regard to the safety, we don't have a major concern with the safety. But for me, there is a major concern about the efficacy and preventing a further thrombotic events in a patient with SLE and antiphospholipid syndrome. So now, what's about DWACs, different agents? Do DWACs offer sufficient protection against recurrent thrombosis when high intensity anticoagulation is recommended, when we use the higher dose of the oral DWACs? There is an ongoing trial nowadays, which called RESPAS, RCT. They use a higher intensity of rivaroxaban, 15 milligram twice daily, and they compare it to the warfarin in a patient with arterial or ischemic brain manifestations and stroke. Till we get the result of this trial, I would not recommend using DWACs for treating our patient. Most of the evidence about the antiphospholipid syndrome, what's about SLE, particularly SLE? Now, there is no RCTs in a patient with SLE. There are a few case reports, very, very few case reports in a patient with SLE who were given or exposed to DWACs with direct oral anticoagulation. And if you look to this table, one of the case series, they reported 3 cases, different agents, rivaroxaban and dabigatran, both pulmonary as well as cerebral and digital, several manifestations. And look here, despite being on the DWACs, patients continue to have another event of a thrombotic events. Therefore, again, in lupus patient, probably the scenario would be worse than antiphospholipid syndrome only. So DWACs should not be used at this moment for our patients. If we look to the most recent recommendations from the antiphospholipid antibody task force, they recommend to avoid DUAX and antiphospholipid antibody patients with arterial thrombosis, and should be avoided in patients with small vessel thrombosis or patients with antiphospholipid-related cardiac valvular diseases. Those with single or double positive, following first episodes of venous thrombosis, who were started already, came to your clinic started already on DUAX, you could continue it. And please, if you decide to continue it, repeat the antiphospholipid antibody panel after 12 weeks. If they have persistently higher positivity or triple, please stop the DUAX and shift them to the warfarin. And again, you should discuss with the patient. If they insist to continue it, discuss with the patient the risk and the benefit for this type of treatment. The recommendation is very clear. If you have a triple who were already in treatment, stop, switch them to the warfarin, because you cannot guarantee the efficacy of these agents in such patients. Any patient who is antiphospholipid with recurrent thrombosis, those medications should not be started at all. Now, when we say lupus patient at higher risk for arterial thrombosis, this takes us to this slide, what's about aspirin in ABS. Aspirin, it could be used in a patient with arterial thrombosis, and if you decide to start the anticoagulation, please keep your patient on aspirin. Now, looking to the Ablasa trial, which is the antiphospholipid antibody salicylic acid antibody, and you look to the aspirin in antiphospholipid antibodies positive patients, it does not confirm the benefit as a primary prophylaxis. But this scenario is different if we are talking about lupus patients. Lupus patients in presence of a triple positivity, it's recommended to start the patient on low dose aspirin to protect them. So patient with lupus, patient with a triple positivity, those with the previous venous thrombotic events are at a higher risk. So probably you could start them on the low dose of aspirin. Now, I'm not going in discussion whether those who have double positivity or those who have triple without absence of a cilia, with absence of a cilia. This is a very controversial issue. Maybe yes, maybe no. It depends on you, and it depends on the patient and the presence of the other risk factors. But you should keep it in your mind, the risk factor of thrombosis, the risk factor of bleeding and hemorrhage is high. So if you have a young patient without a cilia, with only highly positive antiphospholipid, personally, I'm observing them without giving them the aspirin, because the risk of complication is higher than the risk of benefit. But this could be dealt as individual case by case. Because of the time, just to show you that the hydroxychloroquine, it's please mandatory to be started on lupus patients. If you have antiphospholipid antibody with thrombosis, I would recommend to start hydroxychloroquine, because it's clearly reduced the risk of thrombosis by several mechanisms, and it's very safe medication, could be used during lactation, could be used during pregnancy without any side effect. Now, if you look to the vitamin D, now vitamin D deficiency is very common. So there is no evidence to support using vitamin D only to reduce the atherosclerosis progression. So if the patient is having normal level of vitamin D, there is no recommendation to use vitamin D as prophylaxis. Are you using rituximab in such patients with lupus patient or antiphospholipid patient? There is a report about 5 patients with a cilia and antiphospholipid who have a recurrent thrombosis despite an appropriate anticoagulation. 4 of them had no thrombotic events. So the answer of this question, you could use rituximab in a patient who have a refractory recurrent thrombosis despite using an appropriate anticoagulation. When we say inappropriate, we have to look to the intensity of the warfarin, whether it's 2 to 3 or 3 to 4. If it's kept 3 to 4, despite that, still they have a recurrent thrombosis, warfarin has been used in a case series with partial or complete response. So rituximab might have a role in patient with recurrent thrombosis, patient with antiphospholipid syndrome without clinical criteria. Yes, you could use it. Maybe have a role in refractory CAPS. So still, we said it could be used, but there is no strong evidence behind it. Now, belimumab, yes, it's B-cell depleting through the anti-BLyS, but there is no clear clinical data about belimumab in patients with either ABS or SLE with recurrent thrombosis. So at this moment, there is a very, very limited clinical data, and there is nothing support using belimumab in such patients. Complement inhibition through, eculizumab has been described in a patient with CAPS, okay, has been also described in a patient with a triple positive antiphospholipid recurrent thrombosis during pregnancy. So could be used in a patient with catastrophic antiphospholipid syndrome with refractory macroangiopathic disease, but you have to keep in your mind the high cost of eculizumab when you decide to use it. It's very important to keep again in our mind the traditional risk factor, and we have to treat them to achieve the recommended goal in our patients, which is very intensified control of diabetes, dyslipidemia, hypertension, reduce the body weight, encourage them to stop smoking. At the conclusion, DWACS is not recommended by all the different societies, either EULAR or the European Thrombosis and Cardiac also, as well as respiratory societies. All of them, they don't recommend it, except in a very limited conditions where the patient is having single or double provoked, or when you cannot monitor your patient, you can use them. Otherwise, please don't use DWACS in treating our patients. Lupus patients also commonly have this renal disease, and we know up to 70% of our patients will develop lupus nephritis at one time. And be in your mind that DWACS have to be avoided or adjust the dose in the presence of renal disease. And again, there is a concern about the optimal disease duration of the anticoagulation with no clear evidence or guidelines at this current time. There is no or insufficient data about strong recommendation about using the low dose aspirin for secondary prevention in the first antiphospholipid syndrome ATA. Low dose aspirin may be considered in a combination with anticoagulation and antiphospholipid with arterial thrombosis. Please pay attention to traditional risk factor. Biological agents, I think, are very promising, but till this moment, we don't have a very strong evidence. Thank you very much for your listening.
Thank you so much, Dr. Ryan, for your nice presentation. Very nice and almost covering all the aspects of such sensitive. Your comment about the DWAC use in SLE and thrombosis is very nice. We are suffering from these medications as it is easy to use, easy to follow up, but I think it is more or less dangerous.
It is, unfortunately, I found it's used commonly by our colleague in thrombosis clinic. And I understand that particularly in large tertiary hospitals where it's difficult to monitor INR from somebody coming outside the city. But this is not an excuse for our patient. We have to keep it in our mind, lupus, Behçet with thrombosis, there is no strong evidence at all in rheumatology to use DWACS. And if you are going to use it, please explain to your patient the pros and cons about these agents.
Old is gold. Speaking about warfare.
Yes.
You also touched a good point about steroid-induced coagulopathy.
I think, as you know, Dr. Khaled, I am not a man with steroid. I hate steroid because, you know, we see a lot of side effects. Good, you know, one of the things that old school or non-rheumatologists, they start to use steroid frequently. And unfortunately in Saudi, I don't know about Egypt, our colleagues from Egypt, steroid is over-counted. Whenever the patient have pain, they go to the pharmacy, they can buy steroid, increase the steroid up to their mind. Yes, it could relieve the pain. Yes, it could improve the skin rash, but it has to be supervised with intent to stop steroid if possible.
Our professor, Dr. Salah, taught us P prednisolone, P poison.
That's a poison. Salam alaikum.
Salam. Allah hayak Allah, bro.
Thank you, Dr. Ibrahim. Thank you so much for your nice presentation. Then we'll meet you again, inshallah, with the more research.
Thank you very much.
As we mentioned yesterday, rheumatology is a highly growing branch of medicine. And this is our time with my dear great professor, the president of the Egyptian Society of Rheumatology and Clinical Immunology. Professor Dr. Salah is the professor of professors. He's the professor of internal medicine, rheumatology, and clinical immunology in Shams University. We are very happy and proud of your presence, Dr. Salah, my dear professor. Dr. Salah taught me and tens of my colleagues ethics and medicine. The nice yearly presentation here in review. Welcome, Professor.
Bismillah ar-Rahman ar-Rahim. Thanks, Professor Dr. Khalid Fateh, for this presentation, and thanks for your invitation to present my lecture in the 10th annual Saudi German Hospital Riyadh Rheumatology Congress. And thanks for you, as we used to attend this conference, you know, before, but inshallah nearby we will come to you. Our lecture about the year in review in rheumatology. These are my disclosures. Our objective is to have a quick journey through the last year with a few stops along the way, focusing on practical and clinical aspects. We live in exciting times in rheumatology and the clinical immunology nowadays, with many new guidelines and many new drugs. Let us see what is happened last year.
Can you stop sharing and share again? This is the first slide is showing now.
Stop sharing.
The first slide is clear. That's it. The second one is not, yes, rheumatoid arthritis, yes, clear.
Okay, clear?
Yeah. Yes.
Let us see from the start, you know, this, okay?
Objectives. Yes.
Okay.
Excellent. Yes, okay.
The methotrexate for prevention of rheumatoid arthritis, this paper was published recently in Lancet in July 22. This earlier trial included 236 patients with arthralgia who were suspected of progressing rheumatoid arthritis based on MRI detected clinical joint inflammation. The patients were randomized to receive either oral methotrexate up to 25 milligrams or placebo over 1 year, and to see the percentage who will develop true arthritis at the end of this year. We found that both arms, one arm, 19% of cases developed arthritis, the other arm, 18% developed arthritis. So they concluded that methotrexate, initiated as the pre-arthritis stage of symptoms and subclinical inflammation, did not prevent the development of clinical arthritis, but modified the disease course by improving the MRI detected inflammation and the related symptoms and the physical impairment. This trial was done to see the effectiveness of methotrexate in the prevention of development of preclinical rheumatoid arthritis to clinical rheumatoid arthritis. But as you see, this was not actually observed, but as we know that methotrexate is effective in modification of the course of the disease. The second paper, as you know, that the new EULAR recommendations for management of rheumatoid arthritis were published and issued in the last EULAR Congress in Copenhagen 3 months ago. What are the main differences between the newly issued EULAR recommendations 2022 and the ACR 2021 guidelines? As a first-line therapy, ACR noted that if you have a low disease activity, you may use hydroxychloroquine. If we have moderate or high disease activity, you may use methotrexate. In the EULAR recommendation, methotrexate is the first-line choice for all cases of rheumatoid arthritis. About use of glucocorticoids, ACR strangely, for the first time, gave a conditional recommendation against use of glucocorticoids when starting conventional synthetic DMARD. On the other hand, EULAR considered use of short-term glucocorticoids when starting or switching conventional synthetic DMARD to be discontinued as soon as possible, stressing on this point in the new recommendations. About the patients with insufficient response to methotrexate, the ACR, you can add biologic DMARD or target synthetic DMARD. In cases of EULAR recommendation, if we have no poor prognostic factors, you may consider another conventional synthetic DMARD. But if you have a poor prognostic factors, you may add biologic DMARD or target synthetic DMARD, JAK inhibitors, with taking on considerations the pertinent risk factors. About tapering, ACR advised to continue all biologic DMARDs against tapering. But if you are going to taper, they advise to taper first methotrexate, not biologic DMARD or target synthetic DMARD. On the other hand, EULAR advised to discontinue first glucocorticoids and then consider tapering of any of the DMARDs, either biologic DMARD, target synthetic DMARD, or conventional synthetic DMARD, according to the patient situations. And I think this is a more logical approach. What are the main changes in the new 2022 EULAR recommendations? Number 6 recommendation about steroid therapy, as I just told you, they denoted short-term glucocorticoids should be considered when initiating or changing conventional DMARD. It should be tapered and discontinued as rapidly as clinically feasible. And this is very logical, actually. These recommendations is safety based on what? Data from 10 years follow-up of CARE cohort study, and for 16 years on core Evitas registry cohort, there should not increase the cardiovascular risk in patients with cumulative glucocorticoid dose limited to less than 1,000 milligrams. About efficacy, the Nord Star study, famous study in Scandinavian countries, shows that a combination of methotrexate and glucocorticoids was non-inferior to methotrexate plus any of the biologics used in this study for inducing clinical remission. If you have a look here, this is a combination of methotrexate plus steroid. This is a combination of certolizumab plus methotrexate. This is abatacept plus methotrexate, and this is tocilizumab plus methotrexate. As you see, there is not much difference. This combination is non-inferior to other combination with biologic DMARDs. Based on this data, the ELA recommended to use glucocorticoids, but to be discontinued as rapidly as clinically feasible. The other important change in the new ELA recommendation is the use of JAK inhibitors. We know that JAK inhibitors, after publishing of oral severance study, shows that tofacitinib was associated with increased risk for major cardiovascular events and the malignancy. This prompting the recommendation to include risk assessment when prescribing JAK inhibitors. And as all you know, that FDA making a warning box for all JAK inhibitors and make them as a second line after failure of TNF after publishing of this study. How the new ELA recommendations recommend use of JAK inhibitors in treatment of rheumatoid arthritis. See, for lumbar 8 recommendation, if treatment target is not achieved with the first conventional synthetic DMARD strategy, when poor prognostic factors are present, a biologic DMARD should be added. JAK inhibitors may be considered, but pertinent risk factors must be taken into account. Risk factors are age over 65, history of current or past smoking, cardiovascular risk factors for malignancy, and risk factors for thromboembolic disease. I think this is a more wise use for, I cannot throw the whole group from the window because it is an important group, but it may be used in the proper situation and it should be avoided in presence of any of these risk factors. Lastly, about tapering, which I just told you about. Tapering after glucocorticoids have been discontinued, the patient still in sustained remission, it does reduction of any of the DMARDs, either biologic DMARD, target synthetic DMARD, or conventional synthetic DMARD, may be considered according to the patient's situation. I think also this is a more logical approach than discontinuing methotrexate first, as the ACR recommends. What about systemic lupus erythematosus? First, have a look on this, the new definition, DORIS 2021 DORIS definition of remission in systemic lupus. The definition of remission in systemic lupus initiative was started several years ago in order to provide a framework for defining the remission as an ideal target for systemic lupus management, treat to target strategy. But as you know that to define remission in lupus is very difficult, not like rheumatoid arthritis. This is the last definition issued by the DORIS group, DORIS definition. Clinical SLEDAI equal 0. Physician global assessment less than 0.5 on a scale from 0 to 3, irrespective of serology, irrespective of anti-DNA antibodies level or complement level. And patient may be on antimalarials, low dose steroid, this means 5 milligrams or less, and or stable immunosuppressive, even including biologics. This is the DORIS definition of remission of systemic lupus to be used in treat to target strategy to achieve remission or at least low disease activity. This is the last new drugs approved for treatment of systemic lupus, Safnelo or anifrolumab, approved by FDA in August 2021. Anifrolumab is a human monoclonal antibody that blocks the biologic activity of type 1 interferon. According to this trial, which was published in the New England Journal of Medicine, anifrolumab was approved for treatment of moderate to severe systemic lupus added to the standard of care therapy. This trial, TULIP-2 trial, which was published in the New England Journal of Medicine, shows the superiority of anifrolumab over placebo in controlling this moderate or severe lupus after 21 years study, double-blind placebo-controlled trial. Again, anifrolumab or Safnelo is under trial now for treatment of lupus nephritis. This was presented in the ELAR 2021, and TULIP lupus nephritis trial is still in the phase 2 trial. We are waiting for the results. This is about a new drug, Safnelo or anifrolumab for treatment of systemic lupus. Let us have a look on this paper published recently in the Annals of Rheumatic Disease 3 months ago about use of leflunomide versus azathioprine as a maintenance therapy for lupus nephritis. The objective of this paper, of this study, was to compare efficacy and safety of leflunomide versus azathioprine as a maintenance therapy of lupus nephritis. This trial included 270 patients with biopsy-proven lupus nephritis. All patients received the induction therapy Induxan IV for 6 months and the steroids. And then those who achieved renal response randomized either to prednisolone with leflunomide or prednisolone with azathioprine to be continued for 36 months, 3 years. And to see the frequency of flares at the end of these kidney flares after the end of the 3 years. They found that flare occurs in 15% in the leflunomide arm, in contrast to 17% with azathioprine arm, where adverse events was similar in both groups. They gave a conclusion that efficacy and safety of leflunomide are non-inferior to azathioprine for maintenance therapy of lupus nephritis, and so leflunomide maybe provide a new candidate for maintenance therapy in patients with lupus nephritis. Another paper published about the discontinuation of maintenance therapy in cases of lupus nephritis, WIN-LUPUS trial. This was published recently in the Annals of Rheumatic Disease in June 22, 3 months ago. The objective of this trial, we know that optimal duration of the maintenance immunosuppressive therapy in proliferative lupus nephritis is not definitely known. WIN-LUPUS trial is the first randomized controlled trial comparing maintenance of immunosuppressive therapy discontinuation versus maintenance immunosuppressive therapy continuation. In this trial, patients receiving maintenance immunosuppressive therapy completed at least 2-3 years according to the recommendations, either azathioprine or MMF and hydroxychloroquine, or randomized 2 arms. One arm will continue on immunosuppressive therapy for another 2 years. The other arm will discontinue immunosuppressive therapy. We'll see the result after 24 months, 2 years. The percentage of relapse of proliferative lupus nephritis, they found that relapse occur in 12% with the arm who continued immunosuppressive therapy versus 27% in the arm who discontinued immunosuppressive therapy. The difference was nearly 15%. And so they gave a conclusion that immunosuppressive therapy discontinuation after 2-3 years was associated with a higher risk of severe lupus flares. These results call for development of tailored strategies to identify patients who can be safely weaned off maintenance immunosuppressive therapy, assessing by renal biopsy or whatever. But not all patients I can discontinue treatment further. Then we have a look on what's happened in spondyloarthritis. JAK inhibitors for axial SpA, as all you know that upadacitinib, Rinvoq, 15 milligrams once daily was already approved for treatment of ankylosing spondylitis by EMEA in January 2021. But what's recent is upadacitinib also proved efficacy in cases of non-radiographic axial SpA in a new study published in Lancet, August 2022. So it can be used as a treatment in case of also non-radiographic axial SpA, not only ankylosing spondylitis. And as all you know that tofacitinib Xeljanz was already approved by FDA in December 2021 for treatment of ankylosing spondylitis with inadequate response or intolerance to one or more of TNF blockers. As I told you, FDA now after this oral surveillance study now they make the recommendation to use JAK inhibitors after failure of TNF, either in SPA or in rheumatoid arthritis. What about new recommendations for management of axial SPA? The ASSESS-ELAR recommendations issued their new recommendations 2022 in the last ELAR in Copenhagen 3 months ago. The most important changes in these new recommendations, recommendation number 9, TNF inhibitors, interleukin-17 or JAK inhibitors should be considered in patients with persistently high disease activity despite conventional treatment. Current practice is to start a TNF inhibitor or interleukin-17 inhibitor. This is a complete new recommendation. As you see, they put first line maybe TNF or interleukin-17 or JAK inhibitors, but the usual practice, they put now interleukin-17 as the same level as TNF inhibitors to be used as current practice, first as a first line. The recommendation number 10, it is also a new one. If there is a history of recurrent uveitis or active IBD, inflammatory bowel disease, preference should be given to the monoclonal antibody against TNF. In patients with significant psoriasis, interleukin-17 inhibitor may be preferred. This is about the comorbidities, which may make you prefer some biologic over another one. Again, the GRAPPA recommendation for management of psoriatic arthritis published the new issue, the new 2021 update 3 months ago in June 2022. As all you know that GRAPPA, different domains for management, peripheral arthritis, axial disease, enthesitis, dactylitis, psoriasis, nail disease. Again, they included the new approved drug since the time of the older recommendations in 2015, the interleukin-17 inhibitor, interleukin-23 inhibitor, JAK inhibitors, all this included in the new recommendations. Again, they put a new 2 items, 2 domains for comorbidity, IBD, inflammatory bowel disease, and uveitis. And in these cases, as you just told the number about the axial SPA, something similar. If you have an IBD, we use TNF inhibitor monoclonal antibody. Or maybe you may use in this situation also interleukin-12-23 inhibitor. In case of uveitis, use again TNF inhibitor monoclonal antibody or cyclosporin or methotrexate. Of course, the GRAPPA recommendations also assess the treat-to-target concept and consideration of comorbidities while choosing the proper treatment. What about vasculitis? Actually, we have many new things in vasculitis. We have the new ELAR classification criteria for all types of vasculitis, large vessel vasculitis and small vessel vasculitis. This classification was presented first in the ACR conversions last November 2021 and published later. For classification of giant cell arteritis, to apply this classification on large vessel, you have a clinical diagnosis of large vessel vasculitis and to rule out all vasculitis chemicals before applying this classification criteria. To apply this classification criteria, we have certain scores. There is an obligatory requirement, age over 50 in cases of giant cell arteritis. We have some clinical criteria with different scoring. Morning stiffness, for example, 2, sudden visual loss 3, jaw claudication 2, temporal headache 2, scalp tenderness 2, and so on. For laboratory and imaging, you may have ESR and CRP raised, this will get 2, and angiography, so positive temporal artery biopsy or hallucine on temporal artery by ultrasound, it will take 5. This is the highest score for laboratory and imaging. A presence of positive temporal artery biopsy or hallucine on temporal artery biopsy. This only will take 5. If you got among these 10 items more than 6, you can classify this patient as having giant cell arteritis. This is a look on the halo sign in the ultrasound. Ultrasound of temporal artery is recommended by ELAR as the first imaging modality in patients with suspected giant cell arteritis. Presence of non-compressible halo sign like this finding is most suggestive of giant cell arteritis. If you have a patient with high clinical suspicion of giant cell arteritis and positive imaging like this, the diagnosis may be made without any additional testing, with a sensitivity of 67% and specificity of 95%, compared to temporal artery biopsy with sensitivity of 63% and specificity 90%. This means that with the temporal artery imaging with ultrasound may be more sensitive and more specific. And this is the recommendation of ELAR, as I mentioned. For Takayasu, this is the classification. Also, the patient should be diagnosed on clinical basis as large vessel vasculitis, rule out vasculitis mimica. You can apply these criteria, different clinical criteria with different scoring numbers, as you see. And then imaging, according to the number of affected vessels, you may have 1, 2, 3 scores. And if you have abdominal aorta affection, you will have 3. And if you have a score more than 5, this can be classified as Takayasu arteritis. This is a different clinical manifestations, as you see, with different scoring numbers. Ischemic pain, arm claudication, vascular Berwi, reduce the pulse in one arm, difference between systolic pressure in both arms, and so on. This is a picture, MRA, magnetic resonance angiography of aortic arch in case of Takayasu. If you try to see this, you will find here occluded left subclavian. This will take 1. Here, stenosis, partial stenosis, segmental stenosis of left common carotid. This will take another 1, will be 2 grades. If you have a look on the aorta, there is affection of thoracic aorta and abdominal aorta. There is a bifurcation with affection of mesenteric. This will take 3 marks. So this picture alone will take 5 marks for classification of Takayasu arteritis according to this new classification criteria. About recommendation for management of giant cell arteritis, we know that American College of Rheumatology issued a new guidelines in 2021 compared to the older one, 2018 ELAR recommendations. If we have a look on the key differences between the two recommendations, as regards first choice diagnostic tests for patients with suspected cranial GCA, giant cell arteritis, SCR considered temporal artery biopsy is the gold standard for diagnosis. As you see in the classification criteria, they put both together because it is an SCR ELAR combined recommendations. So they put temporal artery biopsy and ultrasonography of temporal artery halo sign, both of them +5 score for each of them. While ELAR, as I mentioned, suggested ultrasonography temporal artery halo sign in highly suspicious case to be diagnosed. About use of steroids, SCR use 1 milligram per kg up to 80 milligrams or equivalent, while lower doses used in the ELAR recommendations from 40 to 60 milligrams. About use of immunosuppressives, SCR recommended to use immunosuppressives added to steroids for all patients, while SCR not to use immunosuppressives in all patients, but only in the refractory, relapsing, or if there is increased risk of steroids in some patients. But both agreed about use of immunosuppressive. If you will use immunosuppressive, tocilizumab is the drug of choice, and methotrexate is an alternative in both recommendations. As all you know that tocilizumab was approved for treatment of giant cell arteritis by FDA in 2017. In 2017, 5 years ago, based on giant cell arteritis Actembra, GIACTA trial done before that time. What's new is the long-term extension of this trial for 3 years which was published recently in Journal of Rheumatology several months ago, and they're confirming the role of tocilizumab in delaying the time to flare and reducing glucocorticoid cumulative dose in cases of giant cell arteritis. About ANCA vasculitis, there's also new classification criteria for ANCA vasculitis because we have a limited time. This is just to know that this is the classification criteria of granulomatosis polyangiitis, and this is for microscopic polyangiitis, and this is for eosinophilic granulomatosis with polyangiitis. Also, all are classification criteria, not diagnostic. Patients should be diagnosed first as small vessel vasculitis. Rule out vasculitis mimickers before application of these classification criteria. As you know, that the newest drug approved for treatment of ANCA vasculitis, FDA approved Tavneos or avacopan for treatment of ANCA vasculitis. Avacopan or Tavneos is an oral treatment, not biologic, used to inhibit the receptor of C5a fragment, complements 5a fragment, which stimulates the neutrophil. This drug blocks the receptor for C5a fragment, and its efficacy proved in a trial advocate study, which was published in the New England Journal of Medicine 2022, and they concluded that at 52 week, by the end of the trial, 65% achieved sustained remission in avacopan group compared to 54% in prednisolone group. This group on avacopan with no steroid, and this group with the classical treatment with no avacopan. They compare both together at the end of the trial after 1 year, and they conclude that avacopan proved to be superior to standard steroid therapy at inducing and sustaining remission in ANCA vasculitis, and accordingly, FDA approved Tavneos or avacopan as an add-on treatment to standard therapy, including steroids, for adult patients with severe ANCA vasculitis in October 2021. This is the recommendations of the treatment of ANCA vasculitis issued by ELAR in the last ELAR Congress in Copenhagen 3 months ago. In patients with suspected ANCA vasculitis, you can recommend PR3 and MEPO ANCA antibodies using a high quality antigen specific assay instead of radioimmunoassay or immunofluorescence. Induction of remission in presence of life-threatening disease, use glucocorticoids plus either rituximab or cyclophosphamide. Rituximab preferred for relapsing disease. For induction of remission in non-organ life-threatening disease, you use combination of glucocorticoids and rituximab instead of methotrexate. This is a difference between this recommendation and the ACR. ACR is still recommending steroids and methotrexate in non-life-threatening disease of ANCA. About use of oral steroids, less doses of steroids to be used from 50 to 75 milligrams, and to be withdrawn over to 5 milligrams over 4 to 5 months. Lower steroids use. This is the same recommendation by the ACR, lower dose of steroids to be used in the induction. Avacopan, this is a new drug which I have just mentioned now, in combination with rituximab or cyclophosphamide, may be used for induction of remission in GPA and MEPA, and it will be important as a part of a strategy substantially reduce exposure to glucocorticoids. Plasma exchange used less than to be used less than before. Plasma exchange is not recommended by the American College of Rheumatology recommendations, but in cases of ELAR recommendation, it may be used in cases of rapidly progressive glomerulonephritis with creatinine more than 3.4 milligrams per dl, but not to be used in case of alveolar hemorrhage like before. For maintenance therapy, they recommended also to maintain on rituximab. Methotrexate or azathioprine may be considered as alternative, but the preferable choice for maintenance is rituximab. This is a new in cases of ELA recommendation. About the duration of maintenance therapy, it should be continued from 24 to 48 months, from 2 years to 4 years. In the ACR recommendations, there is no limited time in cases of maintenance. And lastly, for induction of remission of EGPA, eosinophilic rheumatoid polyangiitis, with life-threatening disease, we may use glucocorticoids and cyclophosphamide or rituximab. This is a new ELAR recommendation issued in the last ELAR in Copenhagen. We have only 2 slides more. Slide about the immune-mediated diseases which may appear after SARS vaccination. This paper was published very recently, 1 month ago. The objective was to describe patients who develop new onset immune-mediated inflammatory disease or flare of already pre-existing inflammatory mediated disease within 30 days after vaccination of COVID. They found that 30% of new onset of patients develop a new onset inflammatory mediated immune disease like pericarditis or polymyalgia rheumatica or vasculitis, while about 69% of patients who already have autoimmune disease develop the flare. I think these numbers are somewhat higher than we expected in our patients. They give a conclusion that clinicians should be aware that fully blown immune-mediated inflammatory disease, as well as immune features not fulfilling the available classification criteria, may occur shortly after anti-SARS vaccination in previously healthy people. And flares of pre-existing immune-mediated inflammatory disease also may occur. This is our last slide about vitamin D and omega-3 in the prevention of autoimmune diseases, published recently in British Medical Journal in January 2022. This study, VITAL study, it is a randomized, double-blind, placebo-controlled, enrolled 25,000 participants, male and female, over age of 50. One arm taking vitamin D, 2,000 units. The other arm, omega-3 fatty acids, 1,000 milligrams daily. And the other arm was placebo. It is a placebo, double-blind, placebo-controlled trial. The primary endpoint was the occurrence of autoimmune disease. They concluded that vitamin D supplementation for 5 years with or without omega-3 fatty acids reduces autoimmune disease by 22%, while omega-3 fatty acid supplementation with or without vitamin D reduces autoimmune disease rate by 15% in comparison to placebo. These are safe drugs, can be used for prevention of autoimmune diseases. Thank you very much for your attention.
Thank you so much, dear Professor. Very nice, updated, wide spectrum lecture as usual. جزاكم الله خير إن شاء الله. يعني very growing branch.
Alhamdulillah. I think there's no time for questions. لو في أسئلة اتفضل.
Only one. About your comment about JAK inhibitors in SPA, this new indication. And you recommend it as a first line of or after failure of biologics.
الإيما recommendation would recommend after failure of conventional synthetic DMARD, but FDA recommendations recommend after failure of TNF inhibitors.
Regarding side effects, same like biologics.
Side effects, concern now after publishing of this oral surveillance trial about the increased incidence of major cardiovascular events and the malignancy and the thrombotic events raise concern about use of these drugs. But as I told you, these drugs are a very important group. They are easily used, oral, once daily, rapidly acting, can be used as monotherapy. And no allergy like biologics, no antibodies, no immune tolerance like use of biologics. So it is, and it covers many cytokines, as you know. It can be used in different diseases, rheumatoid arthritis, ankylosing spondylitis, psoriatic arthritis, psoriasis, ulcerative colitis, atopic dermatitis, very wide range of uses. I think this group is very important, but we should consider these risk factors, and as Ilar announced in the last recommendations for rheumatoid, put pertinent risk factor in consideration: age above 65, cardiovascular risk, thromboembolic risk, and malignancy risk. If you have any of these risks, avoid use of these drugs.
Thank you so much, dear Professor. We are very happy and proud of your presence with us. جزاكم خيرا. We hope, inshallah, to meet face to face, inshallah, next time. Inshallah.
Inshallah, inshallah, inshallah.
Thank you, thank you. جزاكم خيرا. Now we'll shift to the next presentation.
اشيل الشير بس بتاعي.
Stop here.
Stop sharing. Sharing stopped. كده sharing stopped. خلاص. Okay.
Yes, yes. Thank you. Thank you. Now with my dear friend, Dr. Ahmed Al-Ghitani, the nephrology consultant and head of internal medicine department, Saudi German Hospital, Riyadh, with a nice topic as a bridge between rheumatology and nephrology, chronic kidney disease and metabolic bone disease. Welcome, Dr. Ahmed.
Assalamu alaikum wa rahmatullahi wa barakatuh. I am Dr. Ahmed Al-Ghitani. I am a nephrology consultant in Saudi German Hospital, Riyadh branch. Today I am talking about musculoskeletal manifestation in hemodialysis patients, and we are talking about chronic kidney disease and mineral bone disease, or mineral bone disease in chronic kidney disease patients. As we all know, when we see a patient with chronic kidney disease, whatever the reason of the chronic kidney disease may result from diabetes, hypertension, family cause like polycystic kidney disease. All this can result in chronic kidney disease. And chronic kidney disease has stages: stage 1, 2, 3, 4, 5. And stage 3 is divided into 3A and 3B. And also, stage 5 can be on dialysis or still on conservative management. What we face when we see those patients with chronic kidney disease is a major problem in their joints and the bone. They may complain of pain in the joints and bone. They may complain of limited range of movement. Pain is a significant problem in more than 50% of hemodialysis patients and is not being effectively managed. Chronic renal insufficiency, chronic kidney disease, and hemodialysis may provoke complex biochemical disturbance in the calcium phosphorus metabolism. We all know that chronic kidney disease patients or dialysis patients suffer from hypocalcemia, hyperphosphatemia, hyperparathyroidism, and vitamin D deficiency. Where is the problem? The pathophysiological mechanism behind these disturbances are the Okay. And all this may result in I am sorry for this disturbance. And loss of the 1-alpha hydroxylation function of the kidney may result in inactive vitamin D. Inactive vitamin D will result later in hypocalcemia. And the loss of the excretory function of the kidney will result in hyperphosphatemia. So we have hypocalcemia and hyperphosphatemia, and in the same time, hypocalcemia will result in hyperparathyroidism. Hyperparathyroidism in this time, in reaction to hypocalcemia and hyperphosphatemia, is a secondary hyperparathyroidism that may be complicated later by tertiary hyperparathyroidism. Okay. So all this result in disturbance in the calcium phosphorus metabolism and will result in wide spectrum of bone and soft tissue abnormalities named previously as renal osteodystrophy. But now the new name for this disturbance is mineral bone disease in chronic kidney disease. Clinically, most important manifestation of the renal bone disease includes secondary hyperparathyroidism, osteomalacia, rickets, osteoporosis, adynamic bone disease, and soft tissue calcification. And as a complication of the long-term hemodialysis, amyloid deposition may occur, destructive spondyloarthropathy and osteonecrosis, and musculoskeletal infections also may occur. Musculoskeletal problems remain among the main limitation of the quality of life in renal failure patients, whether on dialysis or not. And also in particular, of those treated with long-term maintenance dialysis, renal osteodystrophy continues to receive great attention. I am sorry for the loss of the shared slides. Now let's go back to what we were talking about. Arthritis was present in 82% of patients with end-stage renal disease. Also, arthropathy or painful joints or disruption of the functioning joints occurs in 50% due to calcium biophosphate dehydrogenase deposition, osteoarthritis, calcific periarthritis, or elevated ferritin. These are the biochemical disturbances we found in our patients. Now I will talk about diagnosis, evaluation, prevention, and the treatment also of chronic kidney disease, mineral bone disease. This is from KDIGO, which is the Kidney Disease Improving Global Outcome in the last edition, 2017. Let's talk about the diagnosis. We will start with the biochemical abnormalities. How to monitor, when to measure, and when to make the intervention. First thing, they recommend monitoring of serum calcium, phosphate, parathyroid hormone, and alkaline phosphatase activity beginning in chronic kidney disease stage 3A. Okay, but in stage 3A up to 5D, D means dialysis, it is reasonable to base the frequency of monitoring of calcium, phosphorus, and the parathyroid hormone according to presence and the magnitude of the abnormality and also the rate of progression of chronic kidney disease. Monitoring interval later on according to the stage of chronic kidney disease. For example, now I diagnosed my patient with chronic kidney disease and he has mineral bone disease in the form of hypocalcemia and hyperphosphatemia, and I started to give him some advices about what to eat and what not to eat and what is the medications to replace or to decrease the hyperphosphatemia. So what is the monitoring intervals? For stage 3A and 3B, calcium and phosphorus should be measured every 6 to 12 months. And parathyroid should be based on the level, on the baseline level and chronic kidney disease progression. In stage 4, they are measured every 3 to 6 months, and BTH should be measured every 6 to 12 months. In stage 5, including those on dialysis, stage 5D, they are measured every 1 to 3 months, and BTH should be measured every 3 to 6 months. And also alkaline phosphatase activity should be measured in stages 4 and 5 every 12 months, and more frequently if we have hyperparathyroidism. And in chronic kidney disease patients receiving treatment for CKD-MBD, or in whom biochemical abnormalities are identified, it is reasonable to increase the frequency of measurement to monitor the trend and the treatment efficacy and the side effects. This means that if I will have hyperparathyroidism and I am giving medication like calcitriol or calcimimetic like sinacalcet, we should measure the changes in calcium and phosphorus to measure, to check early the side effects of the medication and monitor its efficacy more frequently than those patients on conservative management. Still, we are in the assessment phase in stages of CKD, stage 3A up to 5D. They suggest measuring 25 hydroxy cholecalciferol, which is the calcidiol levels, should be measured, and repeated testing determined by the baseline value and the therapeutic intervention. And also they suggest vitamin D, that vitamin D deficiency or insufficiency be corrected using treatment strategies recommended for the whole population. There is no specific measures for patients with chronic kidney disease. In patients with CKD, stage 3A up to 5D, they recommend therapeutic decision to be based on the trend rather than a single lab value, the same like we did in calcium, phosphorus, and parathyroid hormone. This regards the 25 or calcidiol. In patients with stage 3A up to 5D, they suggest that individuals with values of serum calcium and phosphorus should be evaluated together. We will take a look on the hypocalcemia and the hyperphosphatemia, but there is no need to make the calcium phosphorus product like before. In year 2009, we were measuring the calcium phosphorus product, and we have a target that we cannot, we have to interfere before we reach this level. What about diagnosis of the bone disease in CKD-MBD? In patients with stages 3A up to 5D, and there is evidence of CKD-MBD disease and or risk factor for osteoporosis, they suggest bone mineral density using a DEXA scan, testing to assess the fracture risk, and if the result will impact the treatment decision. Also, it is reasonable to perform renal bone biopsy whenever possible. The gold standard to see whether this patient has osteomalacia or rickets or renal osteodystrophy or cystic bone disease or whatever the pathology, the gold standard in diagnosis is the bone biopsy. In patients with stage 3A up to 5D, they suggest that measurement of PTH or bone-specific alkaline phosphatase can be used to evaluate the bone disease because markedly high or low values predict the underlying bone turnover to detect early the adynamic bone disease or high turnover bone disease. Also, in patients with stage 3A, 5D, they suggest not routinely measuring the bone-derived turnover marker of collagen synthesis like collagen type 1 C-terminal or other peptides. What about the diagnosis of vascular calcification? Vascular calcification may result in many problems in our patients, especially that they have vascular access, they have sometimes they suffer from valvular disease due to this calcification, and they have high risk of cardiovascular accidents because of these vascular calcification. In our patients, they suggest that lateral abdominal radiograph can be used to detect the presence or absence of vascular calcifications. We can order our patient to have a lateral X-ray on the abdomen. And also echocardiogram can be used to detect the valvular calcification and any other vascular calcifications that may arise, especially in the arch of aorta. They suggest also that patient with chronic kidney disease with non-vascular or valvular calcification to be considered at the highest cardiovascular risk, as I mentioned before. So, in treatment, we target the calcium, phosphorus, parathyroid hormone, and vitamin D. How to start and how to approach with our patients. As we mentioned before, we will take every abnormality alone. For hypocalcemia, our main target is to correct the hypocalcemia without induction of hypercalcemia, because hypercalcemia may result also in vascular calcification, which is a major problem in our patients. Hyperphosphatemia, we will start with dietary intervention, and later on, we will introduce the phosphate binder. And it's better to use non-calcium-based phosphate binder. And for the parathyroid hormone, in summary, we should start with managing the modifiable risk factor like hypocalcemia and hyperphosphatemia, then to take a look on the parathyroid hormone and to start using other medications like calcitriol as active vitamin D to make negative feedback on the parathyroid gland, or to use calcium mimetic and vitamin D analogs. So let's take it one by one. In our patients, treatment of CKD-MBD should be based on serial measurement of phosphorus, calcium, and PTH considered together. And also, they suggest lowering the phosphorus level toward the normal range, and they suggest avoiding hypocalcemia, which is very essential suggestion. In our patients, doing dialysis, it's better to use low dialysate calcium. Why the nephrologist may use high dialysate calcium? Because it supports the circulation. And in patients using high calcium in dialysis, they don't have hypotensive attacks, or they have it less frequently than those using less calcium in the dialysate. So now internationally, it is recommended to have the dialysate calcium concentration between 1.25 to 1.5 millimole per liter. And also, a decision about phosphate lowering treatment should be based on progressive or persistently elevated serum phosphorus. In adults with receiving phosphate lowering treatment, it is better to use non-calcium based phosphate, okay, and to restrict the calcium based phosphate, and I will show why. In patients with CKD, they recommend avoiding the long-term use of aluminum containing phosphate binder. I know that in practice now, mostly nobody is using aluminum based phosphate binder. and in patient with stage 5 on dialysis to avoid dialysate aluminum to prevent contamination, to prevent aluminum intoxication. And this is essential in the practice of any nephrologist who work in dialysis unit to monitor the aluminum intoxication. Let's see about this slide. On the left-hand side, there is a change in the serum phosphorus, as you see with the arrow. With active treatment, the phosphorus is being managed in a good way, and with placebo, it is still in the high range. Let's go to the right-hand side figure. This is lanthanum carbonate, this is sevelamer, and this is a calcium-based phosphate binder, and here is the placebo. If you will see on the measures here, this is the coronary artery calcification change. It is very high in those using calcium-based phosphate binder. So it's better to avoid it as much as we can. But the main limit to its limitation of use is the high cost of sevelamer and lanthanum carbonate and the other phosphate binders. Here, with using calcium-based phosphate binders, our patients may suffer from higher risk for all-cause mortality and vascular calcification, and higher risk for cardiovascular mortality and arrhythmias because of the vascular calcification. Regarding the phosphorus, they suggest limiting dietary phosphate intake. Phosphorus is present in everything, is present in many food and food additives, especially the inorganic phosphorus. Treatment of hyperphosphatemia is very essential. It is reasonable to consider phosphate source, whether it is animal, vegetable, or additives, especially that you will keep in mind that inorganic phosphorus is present in every food supplement. Okay, so dietary recommendation is very essential, and also we may increase the dialytic phosphate removal, whether to have longer dialysis or more frequent dialysis. Treatment of hyperparathyroidism. Before dialysis in CKD stages 3A to 5, we don't have an optimal BTH level, but we are working on the progressive rise or the persistently raised parathyroid hormone. And in this time, we look for the modifiable risk factor like hypocalcemia and hyperphosphatemia and vitamin D deficiency. Correction of these modifiable risk factors may control the parathyroid hormone or the hyperparathyroidism. In adults with CKD, not on dialysis, we can use calcitriol or vitamin D analog, but not routinely used to avoid the danger of hypercalcemia and vascular calcification. In patients with dialysis, which are CKD stage 5D, they suggested to keep the BTH in the range of 2 to 9 times. We may ask, why could we see a patient with 9 times high hyperparathyroidism, like about 10 times or 9 times, and we may say this is an optimal range because we are scared of a dynamic bone disease. So in dialysis patients, we may allow the BTH to go up and to go high, and we correct only the modifiable risk factor like the hypocalcemia and the hyperphosphatemia, because hyperparathyroidism can be treated, but a dynamic bone disease is very difficult to treat, and a dynamic bone disease has higher risk for having hypercalcemia, soft tissue calcification, and a higher risk for fracture, which is very difficult to treat in a dynamic bone disease. They suggest that marked changes in BTH in either direction within this range may initiate or have the challenge to make initiation or a change in therapy. Okay, we will start with the modifiable risk factors, then we may add calcium mimetic, calcitriol, or vitamin D analogs. We can use bisphosphonate, other osteoporosis medications, and growth hormone according to their recommendation in stage 1 and 2. In patients those having osteoporosis and or high risk for fracture, we will treat them like the general population with no modification, because at this time the bone mineral disease or the renal osteodystrophy that result from CKD is not that evident in these stages. But in stage 3A and 3B with BTH within the normal range, we will treat them like normal population. But higher than stage 3 and those patients on dialysis, we will have a look on the biochemical risk factor like hypocalcemia and hyperphosphatemia and hyperparathyroidism, and we may consider bone biopsy to see what is going on, whether it is osteomyelitis, a dynamic bone disease, high turnover, low turnover. We may consider the bone biopsy before treating osteoporosis. Let's discuss the bone disease in kidney transplant. Kidney transplant, in summary, we now did a transplant. What will happen to hypocalcemia? What will happen to hyperphosphatemia, and what will happen to parathyroid hormone? Hyperphosphatemia will be corrected by the normal kidney function or near normal kidney function, because after transplant, we may suffer from some sort of a chronic kidney disease. Hypocalcemia can be replaced if it will not be corrected with the activity of the new kidney in activation of the 1-hydroxylation of the vitamin D to have normal activity of vitamin D, but still we may suffer from hyperparathyroidism. Some nephrology consultants who are working in transplant may like to treat hyperparathyroidism before transplantation and for a reasonable reasons. So if we may suffer from a chronic kidney disease post-transplant, we may follow the same recommendation for chronic kidney disease. You will find here that the name may change. Stage 1, T stands for transplant, and up to 3. This is the frequency of monitoring and when to measure the calcium, phosphorus, and parathyroid hormone. In patients with stage 1T up to 5T, they suggest that using calcidiol, we can measure the level of the vitamin D, and we may correct it to the baseline according to the intervention. And we can use the DEXA scan to check whether we have a fracture risk or osteoporosis in our patient with transplant. And these assessments, it's better to do it as a pre-transplant in the pre-transplant clinic. And also, treatment recommendation will not be different from those people with chronic kidney disease, whether they are transplanted or not. Now, I am proud to let you know about this research. It was published in International Journal of Clinical Rheumatology. The name of the article is Rheumatic and Musculoskeletal Manifestation in Hemodialysis Patients. It was done by Professor Safa Sayed and Professor Tamer Rita from Cairo University, and myself from Ain Shams University with the help of my colleague, Professor Haitham Azzat. We discussed here the frequency of the musculoskeletal manifestation in dialysis patients, in the Egyptian dialysis patients in one of the dialysis units. We took 49 patients with end-stage renal disease on regular hemodialysis. They were included in the study. They were subjected to full history taking and clinical examination. Also, we take the blood sample for calcium, phosphorus, parathyroid hormone, and also DEXA scan was done, and dialysis adequacy was measured by KT/V. These are the results. The age range, they are middle ages, around 55 years old. The weight, dialysis duration, and KT/V, and presence of diabetes, hypertension, hyperuricemia, hyperparathyroidism. If you see here, hyperparathyroidism is present in 29 patients, which stands for about 60% of our patients. Okay. You see here the frequency of musculoskeletal finding in our patients: myalgia, current cramps, flexor tenosynovitis, flexor deformity in the elbow and the knee, arthralgia, arthritis, vasculitis, and osteonecrosis. Also, vascular calcification or ectopic calcification, and I will show you some photos regarding this: destructive spondyloarthritis, fibromyalgia, carpal tunnel syndrome from amyloid depositions, peripheral neuritis, presence of rheumatic factor ANA and anti-CCP was present in some of our patients. If you see here, we talked before about the vascular calcification. In this arrow, yellow arrow, this is the arch of aorta in CT scan. You can see that this study is a non-contrast study, and you see a bone-like arch of aorta. And here also is the cuts for the abdomen. This is the liver and spleen, and this is the abdomen level of cuts. You see all these white matters looks like as if we are using a contrast, but this is a bone-like density in the vascular wall of aorta and other vessels. Here we can see what's called cystic bone disease or brown tumor in the left shoulder and affection of the rotator muscles. So the key messages today, it is important to emphasize the interdependency of serum calcium, phosphorus, VTH for clinical therapeutic decision. We are not treating each biochemical abnormality alone. We are treating all together. Phosphate lowering therapy may only be indicated in case of progressive and persistent hyperphosphatemia. New evidence suggests that excess exposure to exogenous calcium in adults is harmful, and as you see by yourself, is a vascular calcification and ectopic calcification, and it is harmful in all severities of chronic kidney disease, regardless of other risk markers. It is reasonable to limit dietary phosphorus intake when considering all sources of dietary phosphorus, including the hidden sources like food additives. Routine use of calcitriol or its analog in stages from 3A to 5, not on dialysis yet, is no longer recommended. No consensus was reached to recommend cinacalcet as first-line therapy in lowering BTH in all patients with secondary hyperparathyroidism and CKD stage 5D. Thank you.
Thank you all so much, my dear friend. Nice presentation. Congrats about the public application in the international journal. Inshallah. And back to my dear friend, Dr. Ibrahim Mahmoud. Again, Dr. Ibrahim is the chairman of the Medical Specialties Department in King Fahd Medical City. He is the chairman of the Saudi Rheumatology Scientific Council and the Saudi Commission for Health Specialties. He is the vice president of the Saudi Society of Internal Medicine. Hot topic, ANCA vasculitis in focus. Welcome back to Ibrahim.
Thank you, Dr. Khalid, for inviting me again to give this hot topics. This time you give me a very tough topics, thrombosis initially, and again to summarize the ANCA vasculitis in half an hour. So I'll try to do my best to cover the ANCA. We concentrate on the things that relate to the practice and the updates in ANCA over the next 30 minutes. So thank you very much for inviting me to be with you. As you all know, the ANCA-associated vasculitis are mainly three entities or three diseases, the GBA, MBA, and AGBA. These diseases have a common manifestations like involvement of the kidney as well as the lung organs. However, they have some variation that's important when we are dealing with the patient in order to establish the diagnosis, an accurate diagnosis in order to start the appropriate treatment. GBA, as we know, the granulomatosis with polyangiitis that's previously known as Wegener's, is mainly characterized by involvement of the upper and lower respiratory tract and kidney, while MBA is mainly kidney and lung system, while AGBA is lung, but in form of bronchial asthma, and also the other clinical features, including the neurological manifestations as well as the renal involvement. So, as I said, now looking to these three entities or diseases, which under the umbrella of ANCA-associated vasculitis, although they share a common clinical manifestations, there is a high variability in the prevalence of each clinical manifestation. And in MBA, for example, 90% of the pain they have renal, while in GBA, 90% of the pain they have pulmonary. In AGBA, it's around half of them, they will have kidney involvement. The neurological manifestation is far away more common in AGBA as compared to the MBA, and GBA comes in the middle with the neurological manifestations. This is important because there is some variation in treatment of these entities based on the underlying major organ involvements and the pathophysiological mechanisms for these entities. When we talk about GBA, granulomatosis with polyangiitis, or Wegener's syndrome or disease, it's characterized, as I said, by the upper respiratory tract involvement, where it's mainly due to the granulomatous inflammation. And then the lung involvement, which is mainly due to the vasculitic inflammation or capillaritis that manifests as pulmonary hemorrhage. However, it could present with interstitial lung disease and the other cavitary lesions. And then the kidney, it's mainly through the glomerulonephritis, and looking to the glomerulonephritis, it is mainly post-immune glomerulonephritis. There will be no or very few immunoglobulin deposit in case of glomerulonephritis. Now, the upper respiratory tract involvement, which occur in almost all the patients with GBA, it's variable. It depends on the stage or the time of diagnosis of your pain. They might present to you with a mucosal thickening of the sinuses. They might present to you with recurrent chronic sinusitis. When you do the imaging, you will find erosion and destructive sinusitis. If the disease persists for quite long time or inappropriately treated, they might go into spondylotic stenosis. And this is very important because it developed in around 1/5 of the patient. And the treatment, it's different. It depends on the condition with the time of presentation, whether there is an inflammation or only completely sclerosis. And this is very important to be recognized if you are planning to intubate this patient for any procedure. Saddle nose or nasal bridge collapse, it occurs usually in advanced cases. Now, the lung is commonly involved in GBA. It's highly variable. It might, as I said earlier, present with common presentation. Whenever people talk about GBA, they say, oh, this is pulmonary hemorrhage. This is what it looks like, as you see in the left lower side in the CT scan. But it might present with a cavitary lesion, mimicking TB. That's why it's a very, very important part in our society to rule out TB before diagnosing the patient as GBA. And they might present with also interstitial lung disease and a variable presentation, whether they are symptomatic, severely symptomatic, mild symptoms, or asymptomatic involvement. The glomerulonephritis, as we say, it's present in almost 80% of the cases. 20% they might present with a glomerulonephritis. Why this is important? Because your patient might drop initially to nephrology services before development of the other clinical features, or the other clinical features were not a major clinical features that dominate his presentation, and he presents with the glomerulonephritis. So it's very important in any case who presented to you with glomerulonephritis is to go back to the history, explore the history more and more, try to figure out what's the underlying cause of the glomerulonephritis. The disease might present with RPGN, rapid progressive glomerulonephritis, and a quick development of end-stage renal disease, but more commonly present with the evidence of the glomerulonephritis rather than RPGN. Now, histology or pathology, we know it from a rheumatology point of view. It's a necrotizing glomerulonephritis with palsy or very little immune complex. But does histology important to us as a rheumatologist? The answer is yes. It's not only to support the diagnosis, but also for the prognosis. And this is very important. Probably our colleagues in nephrology, they deal with the result of biopsy in details. We just read the biopsy. We are looking for immunodeposit. We are looking for necrotizing glomerulonephritis or no. But again, you should look to the percentage of the sclerotic glomeruli, because this is important in a prognostic factor based on a study that resulted in 2010 that indicate a patient with less than 50% of sclerotic glomeruli and more than 50% are normal, this is called or classified as a focal class. Those patients carry the best prognosis, and the renal survival is much better than those with sclerotic. When there is more than 50% global sclerotic glomeruli, the survival of the kidney and development of the end-stage renal disease is more frequent and more earlier than those with focal, and so on. So kidney biopsy is not only for the diagnosis, but also for the prognosis. It is very useful. Now, the aim of this slide to draw your attention. Now, in 1990, there was a classification criteria from the American College of Rheumatology in order to attempt to classify those type of vasculitis or vasculitic disorders, where polyarthritis nodosa or BAN was in the middle, where it's included between the small and middle vessel vasculitis. And at that time, microscopic polyangiitis, MPA, was recognized, but there was no specific clinical features. So these classification criteria are useful for research, but not for clinical. For clinical, sometimes we diagnose the patient out of the context of these criteria, particularly when we look to the sensitivity, which is important for inclusion. The sensitivity of these criteria is around 85, 88%. So still, there is a sizable number of patients might be missed if you are going to apply these criteria. So after that, in 2012, the Chapel Hill Consensus Conference, they described microscopic polyangiitis as a necrotizing vasculitis with characteristic of pauci-immune glomerulonephritis, and they predominantly affect the glomerulonephritis and pulmonary capillaries, but they clearly indicate that the granulomatous inflammation is absent, and maybe this is a difference between the MBA as compared to the GBA at that time. So, and recently, this before the preparation of this slide was studies not published. Recently, it has been published, these classification criteria for ANCA-associated vasculitis. And the beauty of the recent classification criteria, it's scored. And so, yes, it's difficult sometimes to memorize the scores, but it's very useful because when they achieve a certain number of scores, for example, for GBA at least 5 to be scored, this is likely to be included as GBA. And more importantly, they included ANCA in their classification criteria, because nowadays we know the ANCA plays a major role in diagnosis of the ANCA-associated vasculitis, particularly when we talk about the BR3 C-ANCA antibodies. So as you see here, the involvement of upper respiratory tract, it carries the higher score, and then the C-ANCA BR3 antibody positive, again, it carries the highest score. But importantly, if your patient is having eosinophilia, high number of eosinophils, this gives the patient -4, which makes him unlikely to have GBA. And again, the same story for AGBA and MBA. We'll discuss it after a few minutes. Now, a common question, do I need to biopsy any patient? Can I avoid an invasive procedure? Recently, we know that we could diagnose patients with the advancement of the ANCA and availability of the ANCA, particularly ELISA, okay? With the availability of ELISA in testing the ANCA, you could avoid biopsy. And biopsy in the presence of a high clinical suspicious and positive C-ANCA BR3 or MBO ANCA by ELISA, not immunofluorescence. Now, there is you might not do the biopsy at this time if you have an experience dealing with these cases and the availability of the other collateral surfaces in your center. But in case you are in doubt, or you don't have ELISA, you have only immunofluorescence, and we know the ANCA could be positive in a long list of the causes, and the biopsy is not contraindication, please go ahead and biopsy your patient. So the biopsy is useful to establish the diagnosis. It's very useful for prognosis, but it's not mandatory nowadays, and you can avoid biopsy when the conditions are clear. Now, the AGBA, remember the major or the main presentation of AGBA is bronchial asthma and eosinophilia. Therefore, a criteria from our colleagues from respiratory specialties, if you look to the ERS, the European Respiratory Society, they give also the criteria, and they require a patient to have bronchial asthma with eosinophilia more than 1, okay, or more than 10% of the total WBC count, and they require at least 2 of these clinical features, which including, neuropathy, pulmonary infiltrate, cardio, and pneumonitis, alveolar hemorrhage, palpable purpura, skin rash, positive ANCA test, and the biopsy, which evidence with eosinophilic vasculitis, which again, to me, it's more practical than the previous ACR classification criteria. Recently, we have a new criteria that again score and look to the sensitivity. It increased significantly to be 88 with a very excellent specificity, 98%. And again, if you look to these classification criteria, they require upper respiratory tract involvement in form different than that's mentioned in patients with GBA. Here, it is an obstructive airway, i.e. bronchial asthma or nasal polyps. Okay, and the mononeuritis multiplex, keeping in our mind the most common cause of mononeuritis multiplex is diabetes. We are in third country worldwide with the prevalence of diabetes. So not any patient with mononeuritis multiplex is AGBA. No, we have to rule out the common causes. But if you suspect small vessel vasculitis in the presence of mononeuritis multiplex, the most common cause in this condition is AGBA. And look here to the eosinophil. They give eosinophil a high score, 5, and you need here at least 6. If the patient is having microscopic hematuria, it's -1 because the renal involvement in AGBA is less than half of the patient, around 40 to 45% of patients that will develop kidney involvement. PR3 is against AGBA, but remember, presence of PR3 does not rule it out in the presence of other clinical feature, but it makes this less likely as a first diagnosis. When we look to the MBA here, it does not involve upper respiratory tract at all. So presence of involvement of upper respiratory tract was given -score, -3, but it's associated mainly with glomerulonephritis in biopsy or fibrosis or ILD in CT scan. And actually, there is studies that found that most of the patients who were labeled initially as ILD, idiopathic, with the time they tend to develop MBA. And therefore, it's very important if you have patients with interstitial lung disease, idiopathic, to look for any feature that support the diagnosis of microscopic polyangiitis. So now we know the recent classification criteria, and I think they are doing better performance than the old ACR classification criteria. And the major advance for that is the inclusion of ANCA. Because as you see in the slide, the ANCA previously was reported mainly by immunofluorescence. So either cytoplasmic or perinuclear when it's around the nucleus. This could be possible positive because of various antigens, including myeloperoxidase for P-ANCA and BR3 for C-ANCA. When we talk about the C-ANCA and immunofluorescence, 90% the responsible antigen for it is BR3. So if you have C-ANCA positivity in immunofluorescence, likely to be BR3 positive in ELISA. But the story is different totally when you have P-ANCA positive. MBO, which is important for us when we talk about ANCA vasculitis, it's representing only 10% of such reactivity. Several antigens might lead to P-ANCA positivity. One important point, ANA positive could lead to false positive P-ANCA pattern. And therefore, if you have ANA positive, you might have P-ANCA positivity and it doesn't carry any clinical significance. So this is indicating the importance of using ELISA. That's why the international consensus is to screen all the blood or all the sera by immunofluorescence. Once it's positive, confirm it by ELISA. But unfortunately, there are some labs that goes directly to the ELISA. Some labs, they start with ELISA and confirm it by immunofluorescence. But the ideal way is to start with the immunofluorescence and confirm it by ELISA. Doing such, still there is a problem. That's why we don't depend 100% on ANCA to diagnose the patient with ANCA vasculitis. First of all, there is a diversity of the ANCA target antigen. There is no clear standardization for the assays and for performance of the assays. And one of the major problems in rheumatology referral is application of ANCA testing in a clinical setting with a low pretest probability. We know p-ANCA could be positive in most of issues, infections, inflammatory bowel disease, drugs, and so on. You can name a lot of conditions that could lead to positive p-ANCA. So the ANCA positivity, it depends on the preclinical testing probability. There is also a wide assumption and a wrong concept that the ANCA titer alone may closely reflect the disease activity and therefore should be used as a guide for therapy. But look here, around 20% of patients with GBA and MBA, they have negative ANCA. And up to 60% of patients with EGBA, they have negative ANCA. And therefore, negative ANCA does not rule out vasculitis, and positive ANCA doesn't mean vasculitis. When we look to the ANCA level or titer and the disease activity, the meta-analysis of 9 articles investigating the ANCA level and disease activity report are modestly predictive. So the bottom line here, it's unlikely to have active disease, active vasculitis with a negative ANCA titer. However, positive ANCA titer or mild increment in ANCA titer does not mean this patient is having active disease. So a negative titer would be very helpful, but a positive ANCA does not reflect an active disease. Now, let us talk about the treatment. Whenever you're approaching a patient with ANCA vasculitis, we have to keep in our mind, our goal is to improve the patient's survival rate and to induce the remission with complete absence of the disease activity and to avoid relapse if possible. We all know ANCA-associated vasculitis are treatable in general. But one of the major issues with this type of vasculitis is relapse. Relapse is extremely common. 50 to 70% of patients relapses after the treatment with withdrawal. So we should keep in our mind induction of remission and minimizing the relapses as much as possible. So if you have a patient with a major organ involvement with severe manifestation like alveolar hemorrhage, glomerulonephritis, CNS involvement, mononeuritis multiplex, cardiac involvement, vision-threatening scleritis, it's recommended to go with big guns, recommended to go with an aggressive treatment like cyclophosphamide or rituximab. If you have a limited disease or non-severe disease like sinuses or skin, joint, and limited lung without pulmonary hemorrhage or severe interstitial lung disease, you can start with methotrexate. Now, in non-severe disease, several studies have documented that they, like this study, they compare cyclophosphamide versus methotrexate for induction as well as the maintenance, and they found that methotrexate is not inferior to cyclophosphamide for remission induction of non-severe disease, and we know methotrexate has much less side effect as compared to cyclophosphamide. What about maintenance of remission? This study compared a patient who induced the remission with cyclophosphamide, methotrexate versus azathioprine, Imuran, and they reported clearly there is no differences between methotrexate and Imuran for remission maintenance. So you can use any one of them. What's about Silsipt, which is we use it a lot for treatment of lupus and lupus nephritis. Now they compare Silsipt, mycophenolate mofetil versus Imuran for remission maintenance. Here the story is different from SLE. MMF is less effective than azathioprine for maintaining remission, and therefore for ANCA vasculitis, MMF should not be first line for induction and also not be first line for maintenance of the remission. Cyclophosphamide, the story is a little bit old because we know from different studies that cyclophosphamide is effective. Now, cyclosporin, the first study that indicates the oral steroid is very effective, cyclophosphamide is very effective. And I think when I started practicing rheumatology in 2008, we were using cyclophosphamide orally, but nowadays, after cyclopes, I don't think anybody is using oral cyclophosphamide because it's associated with more side effects, mainly hemorrhagic cystitis. The cyclopes give us an indication that IV is equal effective as oral with less side effect for induction of remission. And then the story of rituximab come up, and cyclophosphamide was compared versus rituximab for induction of remission with RAF trial. And all of you know the RAF trial, which is the trial that lead to approval of the rituximab for induction of remission for GBA and MBA in April 2011. This was comparing cyclophosphamide with the oral with the rituximab, and that was not the standard of care. The standard of care was is the IV cyclophosphamide. That's why rituximab was done, and again came with the same conclusion that rituximab is not inferior to cyclophosphamide for induction of remission. And so we know now we have other approved first line of therapy, which is rituximab, and then it comes to the discussion that studies with rituximab, they excluded some patients with severe manifestation. So which patient you are going to give rituximab, which patient you are going to give cyclophosphamide IV. Until this moment, patients with a very severe disease manifestation, like those with alveolar hemorrhage who require mechanical ventilation, or those with evidence of rapid progressive glomerulonephritis, RBGN, with serum creatinine more than 4 milligram, which equal to around 400 something, more than 400, the recommendation is still to go with cyclophosphamide. Otherwise, you can go with the rituximab as first line of therapy. So presence of pulmonary hemorrhage does not mean you go immediately to cyclophosphamide. You can start rituximab in these conditions. So now we know clearly that rituximab is as effective as cyclophosphamide, but it's not superior to cyclophosphamide. And then what's about remission induction in GBA and MBA? We know now both GBA and MBA, you can use rituximab for induction of remission in any patient except, as I said, those with a severe disease, or those who are intolerant to rituximab, or those who have worsening of disease despite rituximab. You can use cyclophosphamide. Otherwise, you start with rituximab. So what's about relapse? Now we know it's approved to be used for induction. What's about relapse? Relapse, again, occur after rituximab because we know these diseases are characterized by frequent relapses. So what are you going to do in a patient who are induced with rituximab? Are you going to use rituximab for maintenance, or you are using the other line of therapy to maintain the remission? In this study, which is Meristan, they compare the patient to maintain with either rituximab or azathioprine, and they found that those who maintain with rituximab was having less relapses, and they conclude that rituximab is more effective than azathioprine in maintaining of remission. But the question again remains, what's the duration of treatment? For how long you are giving rituximab. Now, again, another question. Are you going to give rituximab fixed schedule every 6 months, or are going to tailor your therapy toward the level of the CD19 and ANCA titer? Now, this study was done, which is Meristan 2, comparing the two regimens, and they found there is no differences in relapses whether you are using the fixed schedule versus the tailored rituximab toward the CD19 level. But those who have a tailored protocol, they were received less rituximab infusions. Personally, I use the rituximab fixed schedule because the test also is costly, and you have to do it every 3 months to make sure that the CD19 or the cell count or the ANCA doesn't come again and the B cells reappear. Now, what's new here? There is a study that's done over a small group of patients. They combine both rituximab and cyclophosphamide, and they give in day 0 both agents. Week 2, they give both agents, and then they continue week 4, 6, 8, and 10 cyclophosphamide IV 500 fixed dose. With tapered dose of steroid, they start with 10 milligram per kg, aiming at the week 20 to reach to 10 milligram, and then they maintain the patient with Imuran. If they cannot tolerate Imuran, they give the patient MMF. Because of high dose of immunosuppressive therapy with steroid, they give the patient also the PPI prophylaxis and so also the PGP prophylaxis. And then they evaluate the patient. They found that the number is small, 66, but they found that there is a significant reduction in risk of death, significant reduction in risk of progression to end-stage renal disease, significant reduction in relapses, and it's potentially to be superior to the standard current of care. Whether this is going to be approved or no, it's still so early, but we keep it in our mind for refractory cases. We could combine these two agents. The plasma exchange, we know the recent study, they said plasma exchange is not effective. But I would like to stress upon that study has some concern. So still the best statement for this, that the utility of plasma exchange is unclear. And we have to keep in your mind that if you are going to use it, keep in your mind that it removes the heavy protein, so it can't be used right away after rituximab. Again, it can't be used right away after the IV immunoglobulin because it's going to remove these heavy proteins. But it might still has a role in those who are having anti-GBM. Remember this study, the Pixivas, they don't report the level of the ANCA. They don't report the presence or absence of anti-GBM. We know it can coexist with this disease, and anti-GBM mandate the use of plasma exchange. And we don't know about the severity of pulmonary hemorrhage in that study. So in bottom line for the ANCA vasculitis, if we have a limited disease, we start with methotrexate and steroid. Severe disease, cyclophosphamide and rituximab could be used. Maintenance therapy, methotrexate, azathioprine, or rituximab. Mycophenolate mofetil is an option, but it's not as effective as the other line for maintenance therapy. Now, the complement activation, I wouldn't take a long time here. It's like eculizumab and more recently, avacopan has been approved for treatment of ANCA vasculitis as a steroid-sparing agents. And that in a study that's published in New England Journal of Medicine, it's clearly indicate that at week 24, it was not inferior, but not superior. But at the end of the trial, it was superior to the steroid with less side effect. So just to use it to minimize the side effect of steroid. But I think the main limitation of avacopan is the price of avacopan. Still, it's very expensive as compared to the steroid, which are very cheap. It's very important when we talk about ANCA not to ignore the AGBA. Usually patients with AGBA require high dose of steroid. And usually, again, the disease recurs after steroid withdrawal. Very few patients get off steroid. And in addition to that, Not all patients respond very well to steroid initially with all the side effect, the metabolic side effect of steroids. You can prescribe steroid alone to those with mild disease, where when we look to the 5-factor score, either 0 or 1, but there is no kidney, no heart, no GI involvement, no CNS involvement. Despite that, relapses occur at a lower doses with steroid, and you need to taper it very slowly. So when we look to the long outcome in patients with AGPA, still 20% of the patients, they have long-term remission, and 10% they die because of the disease. Okay, and even those who have remission, 57% they relapse when the steroid is tapered less than 10 milligram. Unfortunately, all the immunosuppressive therapy that we know, there is no evidence to support their efficacy in patients with AGPA. So no prospective trial specifically addressed the usefulness of any drug as a remission maintenance for AGPA in the presence of the poor prognostic factors. What about cyclophosphamide? Its efficacy against AGPA is less well established as compared to the GBA and MBA. There are very, very few studies that reported its efficacy, and we do know about the subsequent immunosuppressant therapies in such patients. Recently, an agent that block interleukin-5, which is mepolizumab, has been approved for treatment of AGPA, and the approval based on this study that clearly show the significant reduction of the dose of steroid, the median dose of corticosteroid, as you see in the slide, and also significant reduction in relapse in all the type of relapse, including the vasculitic relapse in patients with AGPA. And the time of relapse in those who were given mepolizumab as compared to the placebo was much longer as compared to the placebo. This study led to the approval of mepolizumab. The recent recommendation recommend mepolizumab to be used in a patient with non-severe disease when the steroid is failed as a steroid-sparing agents, and those who have also significant bronchial asthma manifestations. Those who are having predominantly kidney involvement, the recommendation is still to use cyclophosphamide as first line. And if it's failed, you think about the mepolizumab or the B-cell depleting agents. Is there an emerging therapist? Yes, as we said, rituximab and cyclophosphamide, it's an ongoing, it's a very hot topic in ANCA-associated vasculitis. Rituximab with or without belimumab as two agents that completely remove both B cells and memory B cells in COMBIVASC study still is an ongoing. We don't know the result. And also there is a fixed rituximab doses with the oral steroid, the min-PSAM, in attempt to reduce the prolonged use or exposure to the steroid therapy is an ongoing. I don't think there is a time for the disease progression and burden, but we have to keep in our mind, please, the disease burden in a patient with ANCA vasculitis is not only related to the disease itself, but it's related also to the medication that used, and please minimize the steroid as much as early as possible. There is a recent recommendations for treatment of GBA and MBA as well as for the AGBA. And still there is a challenge, would like to share it with you. Some patients that, despite all the presence of available treatment, they have an ongoing disease activity. And what's about the long-term side effect of this medication? The psychological impact of the life or organ-threatening disease, and again, the health-related quality of life complex, it's a major concern in a patient with ANCA-associated vasculitis. We have to keep it in our mind, the titer, it has a modest information with regard to the disease activity, and we should not deal only with the titer to say this patient is having an active disease at this moment. ANCA positivity does not mean this patient is having vasculitis, and negativity does not rule out vasculitis. And thank you very much for your listening.
Thank you so much, Dr. Ryan, for this comprehensive review of all small vessel vasculitis and vasculitis. Jazakallah khair, hope you the best. For sake of time, we'll shift to the sixth presentation in our second day. My dear Professor, Dr. Sulaiman Mayouf, one of the pioneers in the pediatric rheumatology in the region. Dr. Sulaiman is the consultant of pediatric rheumatology in King Faisal Specialized Hospital and Research Center. Is the professor of pediatrics, College of Medicine at Faisal University. Welcome, Dr. Sulaiman. As a nice topic about childhood lupus, overview and updates.
طيب السلام عليكم ورحمة الله وبركاته. Did you see my slide يا دكتور خالد ولا؟
Yes, clear.
طيب I know there is a bit delay in the program. First of all, thank you, Dr. Khalid and Mr. Thamer for this kind invitation, and I'm pleased to participate in the 10th annual Saudi German Rheumatology Conference. In the coming maybe 20 minutes, I will talk about childhood lupus. As you know, this is my outline. As you know, systemic lupus is a chronic multi-system autoimmune disease with wide spectrum of clinical manifestation. It has unpredicted disease onset and course, and it can affect any organ and system at any time. One of the cardinal features of the excessive production of autoantibodies, and I can say it is the best model of immune complex mediated disease. As you know, it's predominantly affect women of childbearing age. However, childhood SLE makes 20% of all cases of SLE. It's very rare in children younger than 5 years of age. When we talk about the incidence among children, male and female ratio is comparable before the puberty period. However, after the puberty, the ratio is almost similar to adulthood. Childhood has been extensively described from different parts of the world, including Arab countries and our country as well. The prevalence and severity differ among ethnic groups. It's known non-Caucasian ethnicity has a high prevalence of childhood SLE. They have younger age at onset and more likely to have nephritis. In previous work from our institution and comparing with other centers internationally, we found Arab ethnicity had severe disease with high mortality up to 5% compared to 2% of Canadian cohort. As you know, like other autoimmune diseases, the exact cause is still unknown, but environmental, hormonal, and immunological features and genetic susceptibility are considered likely etiological factors. This lupus patient characterized by excessive autoantibodies production by autoreactive B cell with help of autoreactive T cell in response to self-nucleic acids and their associated nuclear proteins. This happened due to increased rate of apoptosis and defective clearance of apoptotic necrotic cells, which trigger the type 1 interferon production through various pathways. So one of the explanation is that related defect in gene that regulate the immunological self-tolerance. So the cascade of event will result in the formation of immune complex, which in turn will activate plasma dendritic cells to produce excessive interferon release. If we talk about the nature of the disease, we can subdivide the disease course in 3 phases. Preclinical, when there is autoantibody production, and shortly they start to have some symptoms. If this not treated properly, it will progress to involve multi-organs, and with time they may develop comorbidities and damage. As you know, it is a multi-system disease, and you can imagine any organ system affected, started from skin, joint, CNS, kidneys, heart, and any other organ. And the issue here, the clinical manifestations are variable with unpredicted disease course. If we look as lupus from outside, you can see the synovitis, oral ulcers, nasal ulcers, malar rash. Sometimes they present with discoid rash, and maybe they have Charcot arthropathy, which is probably rare in children, and of course, peripheral vasculitis. From the inside, you may see serositis, pericardial effusion. They may present with cerebral infarcts. Of course, they have hematological manifestation, hemolytic anemia, thrombocytopenia, and the most important, the nephritis. If we look closely to the neuropsychiatric syndrome in lupus, because it's really one of the difficult areas to be appreciated or to diagnose by many rheumatologists, we can subdivide the neuropsychiatric manifestation in central and peripheral. It may present with aseptic meningitis, stroke, encephalitis, demyelinating disease, and one of the difficult areas, the mood disorder and psychosis. And I believe there is full talk about neuropsychiatric syndromes in lupus. One of the peripheral symptoms or presented like polyneuropathy and Guillain-Barré-like manifestation. Of course, the lab results started from cytopenia, and sometimes the pancytopenia related to bone marrow suppression. However, the most commonly is peripheral destruction. Typically, they have high ESR with low albumin, especially if there is proteinuria, and they may have also high or impaired renal function. One of the underestimated manifestations or complaint with lupus patients, the pain, fatigue, and memory defects, and sometimes depression, either related to the disease or the treatment itself. This graph showed the incidence of clinical and laboratory manifestation of lupus. And of course, most of the patients, if not all, they have any positivity, arthritis, arthralgia, and the skin manifestation. Probably this is the most common clinical manifestation. Now, we know that a patient with lupus, they have heterogeneity. And there is a common say lupus is a disease of 1,000 faces. And probably the reason behind it, the genetic and epigenetic pathogenic mechanism, including different pathways and different autoantibodies, the demographics and the ethnicity and race. If you compare different ethnicity, they have different clinical manifestation or the severity as well. Let me share with you a case just to emphasize the heterogeneity of lupus patient, especially in children. This is a 13-year-old girl presented with 1 month history of fatigue, myalgia, lower limb pain, and fever. She had shortness of breath and hypertension, malar rash, and oral ulcers, and found to have severe muscle weakness and proved by MRI and biopsy. And you can see the CBC picture showed pancytopenia with Coombs test positive and high inflammatory markers with high ALT and AST, which is probably related to the muscle or maybe for other reason. And of course, she had full picture of lupus in terms of serology with low complement and other antibodies. Just to remind you again with the pancytopenia, and this patient has very high serum ferritin with high serum triglyceride and fibrinogen, and you would expect this patient to have MAS or macrophage activation syndrome, and I believe this is probably underestimated in lupus patient for good reason, because majority of clinical data available for SLE patient, they have similarity with disease activity, and it's difficult most of the time to differentiate between the disease activity or complication in form of MAS. While in systemic JIA, the story is different, because typically systemic JIA presents with leukocytosis, thrombocytosis, and it will be easy to pick up if the patient presents with pancytopenia, or at least to consider it. So please keep it in mind. MAS one of the possibility or complications, especially with poor disease control. Now, regarding the diagnosis, as you know, we don't have diagnostic criteria, we have classification criteria, and there are different classification criteria. Because of the time, probably I will not be able to discuss all in details. You are familiar with ACR and the revised one for classification, and this is with high specificity and sensitivity, and you know we need 4 out of 11. The most famous one is SLIC criteria. Again, we need 4 criteria, at least 1 clinical and 1 laboratory. And this is all validated for children. And the most recent one is AULR ACR. And it's important to remember ANA positivity is an entry criterion to consider it, or to classify patient for SLE. And we need to have a score of 10 or above to consider or classify patient with the SLE. And recently this is validated for children like other criteria. But again, I just emphasize the positivity of ANA is a mandatory entry criteria. If you have a child with proliferative lupus nephritis class 3 or 4 with ANA, maybe it's sufficient for diagnosis. However, if the lupus nephritis and with the class 2 or 5, they required an additive criteria, because this will not meet 10-point score. This slide showed the overall structure for classification criteria, and of course you can use any one, but probably people now moving to AULR ACR criteria because it's more comprehensive. What is the difference between childhood and adulthood SLE? Of course, there is a similarity, and most of our data, we get it from adult, either medication and even the classification criteria. But if you see the annual incidence among children, it's far from adult cases. In children, we have only maybe 2 per 100,000 comparing to 23 per 100,000. This is, of course, from US data. We don't have our own data. And the children, they have more severe symptoms at the onset, and they have aggressive clinical course, more aggressive than adult. And maybe they have higher frequency of renal involvement at the time of diagnosis and follow-up comparing to adult patient. Children with SLE have more fulminant disease onset and course than adult, and this may result in 2 to 3 times higher mortality comparing to adult. And as expected, they need more treatment, namely steroid. They require more steroid treatment comparing to adult. And we know that it's very difficult to put patient with SLE in remission this is not common in adult patient, and this is extremely rare in children. Yes, we can control the disease even with the best medication, but we cannot keep them in full remission means of treatment. Most of the time, patient died, children would die due to severe disease rather than complication, which is the case in adult patient. This table just to show the manifestation among pediatric and adult patients. And as I said, the constitutional symptoms, hematological and renal involvement more common in pediatric, while in adult they have maybe Zika and pleuritis and arthritis. Children, as a result of severity of the disease and because they have long disease course, they acquire relatively more damage than adult over time. And the damage index, which is validated in children, probably they have more damage during disease course and over time. Now, the disease damage, there is a specific or modified, let us say, for pediatric, because in addition to the one tailored for adult, we add two additional items: growth failure and delayed puberty in children. This is not present in adult patient, and this is very important because this may affect their future. I will not go in details about the other difference, but we have to remember pediatric patient is different from adult, and the management in terms of doses and choosing the medication probably is different as well. Now, let me share with you a suggested management plan for children with the SLE. We advise if there is suspected cases seen by general practitioner or pediatrician, he should refer patient to pediatric rheumatology clinic to establish a diagnosis and to assess the disease activity and severity, and to start or to plan the treatment for that child. And the role of pediatric rheumatologist, he will assess or monitor disease activity and choose the proper medication based on the disease activity, if it's mild disease or severe or moderate. And each class, probably they need different treatment modalities. Now, for the if you receive a new patient or new referral, probably there are different levels you need to screen your patient, and this is probably useful roadmap assessment for children. So the routine screening for all SLE patients, they need full blood count, and they need the Combs test and renal hepatic profile, and of course the autoantibodies, and to monitor the disease activity by inflammatory markers. There are other tests you need to do it probably as a second level for looking for antiphospholipid and echocardiogram, and of course if there is need for screening for MSK, either X-ray or ultrasound or other imaging modalities. We advise to screen patients with the SLE for other autoimmune disease, namely thyroid function test, and because vitamin D deficiency, maybe it's related to or associated with disease activity, it's better to assess the bone health. For advanced or maybe more tests, you need to do extractable nuclear antigen and antiphospholipid antibody screening, and depends on the case, you may need to do more imaging like CT or MRI, depend on the organ involvement. And as part of our routine, we prefer to do AKG and also pulmonary function test for all our patients. For the management, it's guided by disease severity and symptoms and organ affected, but we advise to assess the disease activity index each visit, and probably damage index every on annual basis. I will not go in details about the treatment, but all medication is available. You may consider NSAID, although we don't prefer it because the side effect which affected the kidneys, but steroid, one of the important medication we need to use it. I told you the children, they need more steroid during their disease course. However, with the availability of other immunosuppressive medication, we can get rid of this steroid and taper it smoothly. We have, of course, the Plaquenil, one of the important medications, and those patients need close screening for side effect. And the immunosuppressive medication affect targeting T and B cells is available in terms of Salsept or Imuran, or sometimes cyclophosphamide. And the new modality of treatment, the belimumab, which is approved for children with lupus. As I said, based on the severity and organ involvement, you can choose your medication if there is major organ involvement or no major organ involvement. Typically, all patients, they will go for Plaquenil and low dose of steroid and one of the immunosuppressive medication, MMF or Imuran, and or methotrexate if they have MSK involvement. However, if they have major organ involvement, you may consider cyclophosphamide or even biologic, either belimumab or rituximab, depend on the severity. In summary, childhood lupus is a multi-system disease with broad spectrum of clinical presentation and unpredictable course. Currently, there are no diagnostic criteria for the disease. To date, lupus remains a clinical diagnosis of exclusion. Yes, we can use the criteria to classify the cases, but not for diagnostic purposes. Yearly referral to pediatric rheumatology clinic is highly recommended, and children are likely to have aggressive clinical course than adults. And there have been significant improvement in long-term survival with the available medication. Thank you for your listening, and if there is any question, I will be happy to answer.
Thank you so much, Sulaiman, for this comprehensive review of childhood lupus. There is a big similarity between the childhood and adulthood. We have a single question about the usage of biologics in SLE, childhood SLE. Is it approved already? Do you have any experience about this?
طبعا البيليموماب is approved for FDA approved for SLE and like adult, and we use it a lot. And even without approval, we use rituximab, especially for CNS and if there is refractory hematological manifestation. Sometimes we use it for nephritis as well. So we use it almost like adult.
Yes. Nice talk. Thank you so much, Sulaiman. جزاكم الله خيرا وربنا يجعلها في ميزان الحسنات.
شكرا دكتور، شكرا. السلام عليكم.
وعليكم السلام ورحمة الله وبركاته. With the shortage of time, we'll shift to our next speaker, my dear friend, Dr. Abdulaziz Al-Khalaf. Dr. Abdulaziz is the rheumatology consultant. He's the head of rheumatology unit in King Saud University Medical City in Riyadh. With a nice topic about comorbidities management in RA. Welcome, Dr. Abdulaziz. It's nice to meet you.
طيب، السلام عليكم ورحمة الله وبركاته.
السلام ورحمة الله وبركاته.
Thank you, Mr. Chairman, for giving me the opportunity to present this presentation. This is the second time actually I present after Dr. Prof. المعيوف. How lucky am I, ما شاء الله تبارك الله. وما شاء الله في نفس الوقت يعني على صلاة العشاء. سامحونا. طيب، بسم الله الرحمن الرحيم. I wish that my slide is showing up.
Yes.
يلا بسم الله الرحمن الرحيم. So, is my slide clear
Yes.
now? طيب, I have no disclosure. So I will start with simple daily cases that we face in our practice in the clinic. By the way, I'm not anymore in the King Saud University Medical City. I'm in King Faisal Specialist Hospital as executive health medicine and rheumatology consultant.
This is an update I don't know about.
اي ابديت, اي انا داري, عشان كذا هو ما لي الا اسبوعين دكتور خالد, عشان كذا.
عشان رفع الله
وياك يا حبيبي. The 39-year-old female come to us with a diagnosis of rheumatoid arthritis, started on methotrexate, given IM dipomidrol to control her active arthritis at the moment. So always when you get such cases, there will be some concern from patients, especially on the impact of inflammatory arthritis on their cardiovascular status. So always this question comes, so what are the following measures that you need to tell her to follow? So having the blood pressure monitored, as well as requesting her blood lipid profile, requesting her fasting blood sugar, all of them are required as a screening earlier in patients with rheumatoid in comparison to the general population. So we know that RA is commonly complicated by accelerated atherosclerosis, and there is increased risk of cardiovascular disease. And usually patient RA with cardiovascular disease have worse long-term health outcomes in comparison to people who has cardiovascular disease with other risk factors. The presence of RA usually has impact even in the short term, and this is where it came from the Taiwan study, where they found there is an increase of hospital mortality in such particular patients, especially RA patients. The patients usually RA tend to have high troponin level, having more complications, as I said, with ST segment elevation if they develop MI in comparison to other population. So this is where I always find it a challenge, where is looking for the prevalence of comorbidities in RA patients in the Comora trial or Comora cohort, where actually depression was the highest among all other comorbidities, where we always miss in our clinical practice asking our patients about depression. However, myocardial infarctions, other cardiovascular illnesses were also, like, let's say it's 5%, maybe higher, less in this cohort. Actually, the prevalence of risk factor in cardiovascular and cancer in those patients, in particular with RA, IBD, inflammatory bowel disease, smoking history, diabetes, all of them were looked up in those patients who develop cardiovascular disease, and lipid profile, as well as hypertension were among those patients. So unfortunately, there is a lack of assessment on 40 or even higher in patients with rheumatoid arthritis, looking for their risk factors overall in cardiovascular. So in this cohort trial, they found around 40 to 50% of patients were not assessed appropriately for cardiovascular risk factors. So the risk factors of cardiovascular in patients with RA, it's a multifactorial. You should look for the traditional risk factors. Inflammation has an impact on the cardiovascular, as we know, and also our medication that we use, especially the steroid. Compared with the general population, the prevalence of traditional cardiovascular risk factors are often higher in patients with RA in comparison to other general population. So the relationship between chronic inflammation, cardiovascular remains to be fully delineated, but it has been reported that pro-inflammatory mechanism and has like a underlying pathogenesis of RA contribute to the development of atherosclerosis and promoting cardiac remodeling, as well as alteration in the lipid profile with change in the morphology of the RBCs, which lead eventually to atherosclerosis and damage of the coronary arteries due to T-cell mediated, as we said, inflammation. So the effect of RA in the treatment, like we know that steroid and COX-2 are used sometimes in patients with RA. Actually, not sometimes, even like we commonly see patients with RA get a late like DMARS therapy intervention as well as biologics, and the patients are staying for years in corticosteroid. And this systematic review and meta-analysis actually demonstrated that TNF and methotrexate were actually significantly reduced the risk factor of cardiovascular events in comparison to people with no treatment. And this not only this systematic review and meta-analysis, most of this like studies shows that the early you start treatment and you stop the inflammation, the probability of developing cardiovascular disease are less in comparison to people who started late on treatment. This is a study where it showed the length of the treatment associated at 1 year, 20% reduction on the cardiovascular risk, at 2 years were 40%, at 3 years it's around 50%. The more duration the patient stay on and methotrexate as well as biologic therapy, the risk or the lower risk of developing cardiovascular disease. So what about heart failure? We know that we are not supposed to use anti-TNF in patients who have a class 3 and 4, and we are looking to switch them to another non-anti-TNF medication. What about the interleukin-6 inhibitors and cardiovascular? We always concerned about the lipid abnormalities that we get, how that impacts clinically on the patient. Actually, the studies show there is no like a change or impact exactly on the patients who are using interleukin-6 with lipid abnormalities. So there is no clinical correlation of developing more risk factor of cardiovascular. So in major and adaptive trial, tocilizumab showed some alteration on the HDL particles toward an anti-inflammatory composition. So when you stop the inflammation, probability to stop the atherosclerosis even higher when patient with interleukin-6 inhibitors. So now in JAK inhibitors, we know that the risk of developing VTE is around 3%. In 2019, actually, the meta-analysis of 26 randomized controlled trials comparing patients, or comprising patients, 11,000 patients, indicated that treatment with JAK inhibitors as a class or as individual therapies does not affect the VTE, cardiovascular event, or MACE in patients on RA, at least in the short term. However, in 2021, FDA released that there is an increased risk of MACE, malignancy, thrombotic events, and mortality when tofacitinib in comparison to TNF. So now in the new updated guidelines, so they recommend, or recommendation, sorry, they recommended to, for some patients, we are not considering JAK inhibitors as a first line, which were to be earlier in the previous recommendations. So now we try to avoid JAK inhibitors as a first line in patients who are elderly, having a lot of risk factors of cardiovascular disease. So the point to be considered is always in the EULAR, stressing on the comorbidities in RA. So they are looking as from rheumatology point of view, we need to assess our patients regularly, and we can use a multi way of heart indices that can help us assessing our patients and their risk of developing heart disease. So remember, the management of RA patients with hypertension or dyslipidemia should be carried out according to the national guideline as for diabetic patients. So the patients who are RA when it comes to the hypertension and dyslipidemia management, they are equal to diabetes. So the target blood pressure has to be less than 140/90. LDL has to be less than 100. If only diabetes is there, if there is diabetes with multiple risk factors, target is less than 70. So we need to monitor our patient risk factors every 5 years. Patient overall, they should be always encouraged to stop smoking and having healthy diet with regular exercise so that they can prevent obesity as well as atherosclerosis earlier, especially patients with sedentary lifestyle. What about the risk of malignancy in patients with RA? Lymphoma, there is a double risk in comparison to the general population. Diffuse large B-cell lymphoma is the most frequent encountered lymphoma subtypes. The risk factors, type of severe disease, and persistent high inflammatory markers. And definitely, the longer the patient stay with active arthritis, the more risk of developing lymphoma. So FDA black box warning in 2009 for the use of TNF inhibitors at the risk of developing non-Hodgkin's lymphoma, which came actually from JAMA trial review, which was done in 2006. However, many systematic review meta-analysis came after that a trial which showed no difference in patients who are using TNF, anti-TNF in comparison to other RA patients. However, the longer patients stay on active disease, those are the patients who are really at risk of developing lymphoma. JAK inhibitors, due to the possible risk factor for lung cancer and lymphoma, the ACR recommendation 2022 February, look for alternative, especially in patients with above 65 years of age, patients who are currently or had a history of smoking, patients with other malignancy risk factors like a current malignancy, history of malignancy other than a successfully treated non-melanoma skin cancer. So again, risk of malignancy with JAK inhibitors are still encountered. So we have to avoid it or looking for alternative actually in those particular patients. So there is a study of 12,000 cases with incidence of RA from Swedish registry reported there is no impact actually of methotrexate on the risk of lymphoma. However, many other cohort that shows that still there is a risk of lymphoma in patients with using of methotrexate, and this is like we see it sometimes rarely like we encounter patients with lymphoma, but they are in methotrexate and whenever they are in methotrexate, we tend to stop and look for alternative. Non-melanoma skin cancer and RA, basal cell carcinoma and squamous cell carcinoma associated with methotrexate usage, and squamous cell carcinoma associated also with anti-TNF. And this is where we need to look for alternative in such cases, especially rituximab. So, let me skip this. No, this one is rituximab. This is from 2021. Recommended over other DMARDs for patients who are previously having lymphoproliferative disorders for which rituximab is approved. So rituximab when the patients had lymphoma will be the option for our patients. What about patients who develop non-melanoma skin cancer, non-melanoma or melanoma skin cancers? Always the possibility of using DMARDs other than actually methotrexate will be over the biologics in general, especially anti-TNF or tofacitinib as well. Patients who had previously in the 2015, actually, this is from 2015 recommendations of RA management. So even that time they said the rituximab it's over anti-TNF in patients who had previously or had a history of lymphoma. So patient was found to have hepatitis C antibody positive with negative hepatitis surface antigen, not hepatitis C, hepatitis B core antibody positive with negative hepatitis surface antigen, are you going to consider those patients for biologics or not? So those patients who are having core antibody positive with negative hepatitis C service, we see it frequently in our practice. So what is the recommendation for such patients? So usually when you have a patient who had hepatitis B infection, they strongly recommend like avoiding usage of rituximab in patients with hepatitis core antibody positive. And if you are going to give those patients rituximab, you have to give them the antiviral therapy as a prophylactic measures. And patient who has the core antibody positive of the hepatitis B and hepatitis B surface antigen positive. So those patients, again, like you need to consider them for a prophylactic measures in general, not only rituximab. So the zoster infection and the JAK inhibitors, the risk of developing zoster infection is around 3 to 8%. More actually, like with a high dose of JAK inhibitors, it was among more of Japanese and Korean patients. Patients who had absolute lymphocyte counts less than 1,000. A patient who had long-standing RA patients who are the risk, those are the one at risk factor of developing zoster infection. So in 2019, recommendations for vaccinations with autoimmune disease. So we have to remember or remind ourselves about the bunch of vaccination that can be considered, especially pneumococcal vaccine, zoster vaccine, and now we have the killed one that can be used in our patients, especially who are at high risk, especially who are above the age of 50. So the pneumococcal vaccine, don't forget that we have two types of vaccine, the Prevnar 13 and the polysaccharase 23. So you have to recall this one and put in your mind the pneumovax decrease the risk of developing pneumonia in our patients. And we usually give them the Prevnar 13, and after 8 weeks, we give them the 23, and every 5 years, we give them the 23. The depression in RA patients, it's 4 times higher in comparison to general population. Prevalence up to 40%, as I showed you earlier. They have poor quality of life, and don't forget this depression is treatable. Patients with low socioeconomic status have more risk to develop depression in comparison to other patients. It's more common in female and younger age, especially that they will stay with medications for the rest of life, so they get depressed because of that. And the systemic inflammation may contribute even to depression. And we see this with the patient who has a relapse, they get depression because of the pain as well. So this is again the EULAR recommending that we look for, screen our patients for depression in our practice. So the osteoporosis, the incidence of osteoporosis in comparison to other population is higher among RA patients, with a rate of fracture of 1.5 times higher in comparison to the general population. And the risk factors, as we know, steroid is one of them, and most common actually risk factor in our patients. So again, they recommend screening our patients most of the time in our clinical practice in the EULAR by doing a DEXA scan to be done every 3 years. The total DEXA and the FRAX based approach intervention threshold may be useful strategy for a treatment of osteoporosis and glucocorticosteroid-induced osteoporosis. Optimal management of RA patients with osteoporosis includes treat to target, a strategy for disease control, and anti-osteoporotic medication. And thank you.
Thank you so much, Dr. Abdulaziz, for this comprehensive, nice lecture. Really, rheumatoid arthritis is not a purely articular disease. It is a systemic inflammatory as well.
Yeah, and we actually we need to learn a lot about comorbidities. Unfortunately, the concern that because of our busy clinic, we don't do much of screening for such patients.
We are sorry, Dr. Abdulaziz, for the delay of the lecture. I know you have no time, but it's a pleasure and honor to have you in our symposium for the second time. Thank you so much. Now, ختامها مسك إن شاء الله with my dear friend Dr. Abdurrahman Rashid. Dr. Abdurrahman is a pediatric rheumatology consultant, King Abdullah Specialized Children Hospital. Dr. Abdurrahman is one of the nice figures in the pediatric rheumatology. He has a nice presentation today about the ADA2 deficiency. Welcome, Dr. Abdurrahman.
Thank you very much, Dr. Khalid, and thank you for the kind invitation. I know it's probably the last session today, and probably people are so tired, so I would go quickly over the subject, and I would just probably concentrate on the important things. ADA2, what's the peculiar about this? ADA2 was discovered recently in 2014. In fact, behind some causes, genetic causes of polyarteritis nodosa, mainly in children, but also in adults. So I think it is important for pediatric and also adult rheumatologists. And why is that? Because the treatment approach in ADA2 is different from the regular approach for polyarteritis nodosa. So those patients, they respond to anti-TNF. I am still remembering one of the pearls by Dr. John Stone. He emphasized that in cases in adult patient with polyarteritis nodosa, it's usually a monophasic disease. But if it is a chronic course, so you should consider ADA2 among your differential diagnosis. Why? Because this would change your therapy. Also, ADA2 was found behind some causes of Sneddon syndrome that occurs in adult patients. My objective is to describe the pathogenesis of ADA2 deficiency and to discuss treatment modalities from international and local data. And we just submitted a paper about phenotype of our local experience and has been accepted for publication. So as introduction, adenosine deaminase 2 deficiency is a monogenic autoinflammatory disease. It affects multiple organs with highly variable clinical presentation, and we'll come to that. Adenosine is a purine nucleoside generated from hydrolysis of ATP and degradation of endogenous nucleic acid. We have two ADA, one ADA1, which the absence of ADA1, it results in severe combined immune deficiency. And ADA2, this would result in the disease that I'll speak about. The ADA2 and also ADA1 is very important to convert adenosine to inosine and deoxyinosine. ADA1 it converts adenosine intracellularly, while ADA2 it converts adenosine to inosine extracellularly. ADA1 and ADA2 are not functionally redundant, means everyone will not function instead of the other. ADA2 found to be elevated in plasma in association with infection, autoimmune diseases, and malignancy. And in fact, it is found to be a marker in some of the autoimmune disease. In vitro studies with human cells have suggested a potential role of ADA2 in macrophage differentiation and angiogenesis, and we'll come to this in detail. So the first paper was described in 2014 by two independent articles. The first one from NIH from USA, and they found that some pediatric patients whom they have early onset stroke and vasculopathy were associated with a mutation in the ADA2. And they found that their patient is having recurrent fever, high inflammatory markers, early stroke, livedo racemiosa or reticularis, hepatosplenomegaly, and systemic vasculopathy that resemble polyarteritis nodosa. And in those patients, they discover, because there was one family member affected and it runs as autosomal recessive, so they were able to discover the gene with the loss of function ADA2 mutation in all of their patients. In fact, they described 9 patients. And when they did the experiment on the zebrafish, because zebrafish, it contained ADA2. So when they did a knockout mutation, they found that zebrafish developed intracerebral bleed and neutropenia, which confirm probably the causality between the deficiency and the manifestation. The other cohort also in the same issue of New England Journal of Medicine from Middle East and Turkey and other countries, they found a mutant adenosine deaminase in polyarteritis nodosa vasculopathy. And they found that their patient is having fever, livedo racemiosa, Raynaud's phenomena, some skin manifestation, hypertension, neuropathy, and aneurysms that resemble polyarteritis nodosa. And they found the biallelic loss of function mutation in ADA2 in 21 patients. And majority of their patients were under 10 years of age. However, in their reports, probably you could see that some patients, they present in adulthood. Like in this patient, he's a 59-year-old, and he presented with leg ulcer, with leukocytoclastic vasculitis, and panniculitis. Another patient, 18 years old, who presented with mainly cutaneous feature that resemble polyarteritis nodosa. Again, another patient who is 20 years of age, who presented with different manifestation of skin, renal, CNS, and granulomatous panniculitis. And this, in fact, the discovery of the disease would for sure impact the treatment. This is the gene for ADA2, and it contains 10 exons. And the protein, the ADA2 protein, it contains signal peptide dimerization and catalytic domain, especially dimerization and catalytic domain, very important for protein structure, and any mutation in those sites, it would result in disruption of the protein function. Again, this is the different mutation discovered in ADA2 gene. So the function and pathogenesis, ADA2 is well expressed in myeloid cells. So if there is ADA2 deficiency because of a mutation, this would result in accumulation of adenosine, because there is no more conversion of adenosine to deoxyadenosine. And this accumulation would result in dysregulation of netosis of the neutrophils, and to make them more active with the release of tumor necrosis factor alpha. and ultimately would result in the vasculitis. Also, ADA2 is very important in macrophage polarization and converting macrophage from M1, which is inflammatory, to M2, which is anti-inflammatory. So if there is deficiency of ADA2, the macrophage will remain active. They will not convert to M2. Also, ADA2 apparently is very important for endothelial cell integrity. So if there is deficiency, this will alter the endothelial cell integrity, and this would result in some manifestation of vasculitis. Also, ADA2 is very important for B cell differentiation from naive B cell to mature B cell. So if there is a deficiency, this would result in some B cell dysfunction and ultimately low immunoglobulin. This is one of the study done to examine the role of the interferon type 1, which is interferon alpha and beta in ADA2. And they compare it to another disease, which is called Aicardi-Goutieres disease, which is a type 1 interferon disease. And they look at their gene expression, and they found that in ADA2, they have upregulation of type 1 interferon as compared to those patients with Aicardi-Goutieres and healthy control. This is another one from Italy, where they have 5 patients, and they also the same thing, they try to examine the role of type 1 interferon, and they found that ADA2 deficient patients, they are having high interferon or type 1 interferon. And when they treat them with anti-TNF, they responded very well, and the type 1 interferon score has dropped as compared to healthy control. They also compare them to some other diseases that have interferon role in their pathogenesis, like JDM, SLE, and they found that ADA2 probably is having also high type 1 interferon as compared to JDM, SLE. But patient with Aicardi-Goutieres, which is a pure type 1 interferon, is having higher signature as compared to healthy control and other rheumatic diseases. So probably all of this confirm that type 1 interferon has some role. This is another study done by Japanese, and they looked at type 1 and type 2 interferon. Type 2, which contain interferon gamma. And they found also by heat map upregulation of the genes of the type 1 and type 2 interferon as compared to Aicardi-Goutieres and Candle. Both of them, they are type 1 interferon. Here they studied the chemokines for type 2 interferon, which is interferon gamma, and they found as compared to control that they have upregulation of the CXCL10, and after treatment with anti-TNF, type 2 interferon has normalized. The same thing here down for type 2 interferon with interferon gamma, and after treatment with anti-TNF, the interferon gamma has decreased, and also IL-18, which is known as interferon gamma inducer cytokine. This is an elegant and nice study done by the NIH, and they examine the immune histochemistry in skin biopsy patient. So here we have the control. The green color here, it resembles the endothelium. The red color here in this patient resemble the signature of interferon, of tumor necrosis factor alpha. And after treatment with tumor necrosis factor alpha blockage, you could see that the tumor necrosis factor alpha signature has resolved, also in the other patient, and resumption of the integrity of the endothelial cell. So this is proved the efficacy of the pathogenesis of tumor necrosis factor alpha in this disease. And when they examined it in the heat map, they found upregulation of the interferon pathway and NF-kappa B pathway. This is another study. They try to examine the role of netosis in the disease. So if you could see here, this is a type of leukocytes, LDG, that increased in some patients with rheumatic disease, and those leukocytes, they have ability to produce more netosis. And if they compare it with control, patient with SLE has more netosis, also in patient with ADA2. Here, they just try to add more quantity or amount of adenosine, because we know ADA2 would convert adenosine to deoxyadenosine. So when they, in patient with deficiency of ADA2, when they increase the amount of adenosine, they found that the degree of netosis has increased. So at the end, it seems that adenosine, or the when it accumulated, it attached to a receptor in the neutrophils and stimulate them to produce more nets. And this net would stimulate macrophages to produce tumor necrosis factor alpha. So adenosine will trigger NET via engaging specific receptor in the neutrophils, and genetic deficiency of ADA2 result in enhanced adenosine-mediated NET formation and subsequent TNF production in patient with DA2. And probably this is the main cytokine playing role in ADA2 deficiency, which result in vasculitis. So to sum up the pathogenesis, there is a role, probably the main role is for TNF alpha, and this is also proved by treatment. There is a role for NF-kappa B upregulation, type 1, type 2 interferon, and also neutrophil and macrophage activation. This is probably would help us in patients who they may have contraindication for TNF alpha, so you could use other alternative treatment. So probably medication against type 1 and type 2 interferon may work. This is the clinical phenotype. The clinical phenotype is very wide, but for us as a rheumatologist, they presented to us with vasculopathy and inflammation. So they present like another type of vasculitis, especially polyarteritis nodosa, with constitutional symptoms, with different skin manifestation, with CNS and musculoskeletal, renal, and cardiopulmonary and GI manifestation. And the common manifestation on the right side of the slide, livedo reticularis, fever, skin vasculitis, stroke, neuropathy, and some patients, they may have immune deficiency feature, because ADA2 is very important for differentiation of B cells to produce immunoglobulin. So those patients, they would have, they may have low IgG or low IgM. Also, some patients, they may present with bone marrow failure feature. So they may present with leukopenia, anemia, or thrombocytopenia. So in patient with picture of polyarteritis nodosa and having thrombocytopenia or leukopenia, you should consider ADA2 deficiency in those patients. This is again a different manifestation with their percentage. So for us as a rheumatologist, I went through the literature and I found ADA2 could present with polyarteritis nodosa. So you need to consider it if it is early onset, if more than one family member affected, and if it is refractory to treatment. refractory to the regular treatment of polyarthritis nodosa. Some patients with ADA2, they may present with vicious disease-like presentation with oral and genital ulceration. Also, some patients, they may present with another type of autoinflammatory disease. For us as a pediatrician, like mevalonic kinase deficiency and haploinsufficiency 2-like presentation. They may present also like Castleman syndrome, like presentation, like ALPS-like disease. ALPS, they presented with autoimmune thrombocytopenia, anemia, or leukopenia, and generalized lymphadenopathy. They present with antiphospholipid syndrome manifestation, with the Sneddon syndrome, especially in adults. And there is a few reports about lupus-like disease underlie the presentation of ADA2. And some patients, they may have just a pure bone marrow involvement or picture of common variable immune deficiency. So why this phenotypic variability? Probably this would depend on the type of a mutation and the area of a mutation, and we'll come to that. It also depends on residual ADA2 enzymatic activity. We'll come to this also. There may be also epigenetic that play a role in the phenotypic variability, some environmental factor, or some other gene modifiers. So in this study by Turkish investigator, they found that catalytic domain mutation associated with hematological manifestation, while dimerization domain associated with polyarthritis nodosa-like feature. So this is with probably the area of a mutation and the part of a protein affected would result in the manifestation. This is also from the Boston, where they found that if there is residual ADA2 activity, usually they present with vasculitis-like presentation, but if there is and this is associated with the missense mutation. But if there is no ADA2 activity at all, this is associated with bone marrow failure and pure red cell aplasia. And this is associated with deletion of frame shift mutations. The diagnosis of ADA2, when you find the compatible clinical presentation with biallelic mutation in ADA2 gene, or if you do the enzymatic activity for ADA2, if it is absent, this would confirm the diagnosis. With whole exome sequencing or Sankar sequencing sometimes can miss some mutation, especially if there is deletion or duplication in the gene. The treatment used for ADA2 in the literature, corticosteroid, but those patients usually they only respond to high doses. Fresh frozen plasma, because it contains ADA2 enzyme, but this is in fact is not practical due to the short half-life of fresh frozen plasma. Azathioprine, cyclophosphamide, methotrexate have been used without any efficacy. Mycophenolate mofetil may be effective for cutaneous manifestation. Cyclosporin, it's sometimes helpful for patients with pure red cell aplasia secondary to ADA2 deficiency. And in fact, we had one patient who had pure red cell aplasia who required frequent blood transfusion. And when we start cyclosporin, we could stop the blood transfusion. Thalidomide in some Italian cohort, they said it's effective, and probably because thalidomide, it inhibits the NF-kappa B and ultimately would inhibit tumor necrosis factor alpha. However, as you know, the thalidomide, it has side effects, especially in the peripheral nerves. Anti-TNF alpha therapy is very effective, especially for vasculitis and autoinflammatory manifestation. What we mean by autoinflammatory, if the patient is having recurrent fever or episodic type of presentation, episodic inflammation. Rituximab, it was found that it's not effective, especially for preventing stroke. Tocilizumab is good for Castleman manifestation, but not for stroke. Also, anti-IL-1, it's good if the patient is having amyloidosis, but not for stroke. This is done by NIH group, and they found that fresh frozen plasma probably is not effective due to the short half-life. But if you see on the right side of the slide, after starting anti-TNF, no one of their patients have stroke. So it's a protective anti-TNF. It's proved to be protective against stroke. And the stroke, of course, caused by vasculopathy in the CNS blood vessels. Bone marrow transplant is a curative, especially for all the manifestation. Bone marrow failure, immune cytopenia, or if there is associated lymphoproliferative disease or immune deficiency. So bone marrow transplant is very effective for this. And in fact, those patients whom they have bone marrow failure, they have immune deficiency feature, usually they do not respond to anti-TNF. And the only cure is by bone marrow transplant. And it's it seems it's very effective with survival. When they tested for 30 patients, the survival more than 95% and only one death because of para-influenza pneumonia virus, and this is due to the procedure of bone marrow transplant with induction and immune suppression. Gene therapy is a promising and coming in the future, and it showed some efficacy in vitro studies. Our local data, we had 21 patients. In fact, the number probably more than this in our publication, but this is when we collect the cases at the beginning with 19 homozygous mutation, 1 compound heterozygous, and one has 1 mutation but has Hodgkin lymphoma and neutropenia. So those patients, they could have lymphoproliferative disease up to the Hodgkin lymphoma. And the common mutation in the exon 10, and the enzymatic activity was measured in 6 patients, and it was very low on most of them. One of them, in fact, he had a low residual activity. It's mainly more frequent in female, and the age range from a neonate to 6 years for 20 patients. But 1 patient was adult and diagnosed at 24 years of age with skin rash resembling polyarteritis nodosa and leukopenia. All of them has hematological manifestation except 1. 7 with recurrent fever, 4 with myalgia, 5 with oral ulcers, 4 with Hodgkin lymphoma, 14 of the patient have normal ESR or CRP. And probably the main manifestation in those patients are hematological. Some patients, they have low IgG or IgM. 2 patients, they develop CMV viremia, and this is in fact even before the immune suppressive medication. 16 patients having hepatosplenomegaly and 6 patients having ischemic stroke. So 7 of the patient on anti-TNF, and they have no more active vasculitis or stroke after starting anti-TNF. 4 patients on G-CSF for leukopenia and neutropenia because it was difficult to be managed by anti-TNF. 3 patients blood transfusion dependent. 1 of them, in fact, responded very well to cyclosporine. And 1 patient had successful bone marrow transplant, and the patient is currently not on any medication. 2 deaths with infection prior to any therapy, because some patients, they may have some immune deficiency feature. And this is resembled on the graph. So my home message, ADA2 deficiency has a wide clinical presentation. It affects children and adults. The manifestation include vasculitis, immune deficiency, and hematological manifestation. Tumor necrosis factor alpha is one of the main cytokine for the pathogenesis of vasculitis and autoinflammatory feature in ADA2 deficiency. And anti-TNF alpha medication are very effective in managing vasculitis and preventing stroke in ADA2 deficiency. Hematological and immune deficiency features usually do not respond to anti-TNF, and those patients may require bone marrow transplant. And the bone marrow transplant is the only curable modality for ADA2 deficiency. And thank you very much for your listening. Happy to take any question.
Thank you so much, Dr. Abdurrahman. A very nice, comprehensive one. Day after day, I'm realizing that pediatric rheumatology is completely separate than adult one. About the steroid use in ADA, what's your recommendations in the dosing?
Yeah, well, the recommendation is just to go directly for vasculitis and autoinflammatory feature for anti-TNF. Steroid in low doses usually is not effective. So you will not able to wean steroid from those patients, especially if the patient is having a stroke. And by the way, sometimes those patients, they may be asymptomatic. They may have lacunar stroke. So it may appear in only neuroimaging picture. So those patients with a feature of a stroke, they should be started on anti-TNF. Also, the polyarteritis nodosa manifestation, they are usually resistant to therapy and they respond very well to anti-TNF.
Do you recommend any type of anti-TNF?
Well, they used different. They used Enbrel, they used etanercept, they used adalimumab, and they used also infliximab. All of them are almost, they have the same efficacy.
To start it early, as early as possible.
Right, if the patient is having a vasculitic feature. However, the challenge, if this patient usually present to our colleagues in hematology, and when some patients, they do not have vasculitic feature, they refer them to us because those patients, they have association with vasculitis. So if the patient is having only bone marrow features without vasculitis, people really not on agreement to start anti-TNF. Or when do you start anti-TNF? In those patients whom they didn't have any evidence of vasculitis. Because we know anti-TNF has less efficacy in patients with bone marrow or immune deficiency features. So in those patients, probably you would do surveillance and screening. If they develop vasculitis, you have to start. Because we know that some patients, they may develop vasculitis during adulthood, not during pediatric age group.
Nice. Thank you so much. Very nice presentation, Dr. Abdurrahman. جزاك الله خير وحسن مسك الختام. It's an honor to join with us every year. Thank you so much. جزاك الله خير. We came to an end for the second day for our symposium. جزاكم الله خير. Thank you so much for joining us and being patient till the end. Inshallah, we are waiting for you tomorrow, inshallah, at 4, the last day, Mecca time. نسأل الله لنا ولكم العافية. جزاكم الله خيرا والسلام عليكم ورحمة الله.